I only received email from two, only from Dahiyah and Aklan. There's another presentation, isn't it?
I'm sorry, doctor. You didn't receive my slide?
I only received two.
The child with easy bruising. I did email yesterday.
Is it? What
Yeah.
time?
I emailed before 5 yesterday.
Is it? Probably wrong
Yeah,
email
it's
ke apa ke.
already
Masuk
sent.
dalam ni.
Ayaka, I'm so sorry, doctor.
It's okay. Let me check in the spam. Kalau masuk dalam spam. Tak apalah, it's okay. It's okay. It's alright. It's alright. Let's continue. It's okay.
Can I proceed,
Sorry.
Doctor? Can I proceed? Okay. So, Bismillahirrahmanirrahim. So, I will be the first presenter for today's session. So, we will cover 3 topics for today. So, I'll start off with topic the pale child, and Nadira will continue with the presentation of the child with bruises, and the last presenter will be Aklan, and he will present about the child with jaundice. So, this is my outline. So as we know, the topic is the pale child. What is the first come across our mind is the child is paler, right? Chest is white. So it might be due to anemia. So this is the outline. Sorry, I cannot see my slide. I have to hide the. Sorry, Doctor. Okay. Okay, so this is my outline. I'll start with definition, the common causes, the history taking part, and physical examination, investigation, a bit of management later. So what is anemia? So based on the Nelson, the definition is the anemia is hemoglobin or hematocrit value that is less than below 2 standard deviation for the mean age and gender, which means that the hemoglobin level is varied by age and also gender. Up to date, much simpler definition, which define the anemia as a reduction of the red blood cell or blood hemoglobin concentration. So anemia is not a diagnosis, it's a lab finding that warrants us to investigate more about it. So it is a common presentation that affect about 20% of children during their childhood. So this is the summary of hemoglobin level. I take it from Sunflower. So for neonates, we can consider anemic when the hemoglobin is fall below 14 gram per deciliter. For infants, 1 month to 12 months old baby, the hemoglobin level slightly lower. So we take it anemic when it falls below 10. And for more than 1 year to 12 years old, anemia is considered when the hemoglobin falls below 11. This is much details about the variation of hemoglobin in our PITS protocol. So it is important to remember that it is varied by age, and there is not actually one value for all children. So it's just the same. You can refer to this table. For neonates, just below 14, less than 12 months. You can see my cursor, right? Hello? Okay. I hope you can see my cursor. Okay. For less than 12 months, we take it as below as 10. And for more than 12 months to 12 years old, we take it as less than 11. Okay. That's for normal range. So let's understand a bit about the pathophysiology. What are the causes of anemia? So first, we can understand it based on the underlying pathology, which is the impaired production, destruction, and also blood loss. And it also can be classified based on the patient's profile, which I show you later. So the first one, which is the impaired production of red blood cell. So a bit of physiology of production of red blood cell. We know that it is formed through erythropoiesis that occurs in the bone marrow, which is stimulated by the hormone erythropoietin produced in the kidney. And the production of RBC needs its building blocks, which is comprised of iron, folate, and also B12. So any failure at this process can cause impact production of RBC and later will cause reduction of the RBCs and cause anemia. So let us take a look at the first problem. When there is problem at its building blocks, which is iron, folate, and B12 deficiency, which can be found in the iron deficiency anemia, folic acid deficiency, vitamin B12 deficiency, which both of these can cause a megaloblastic anemia, and protein energy malformation. And the most common causes of anemia in childhood is iron deficiency anemia. The next one, when there is a problem for the hormone production, which is the erythropoietin, such as in case of chronic renal failure, also can cause impact the production of the red blood cell, and it will cause ineffective erythropoiesis. The next one, when there's problem at the bone marrow itself. So first, it can due to the bone marrow suppression and infiltration, such as in bone malignancy like leukemia and lymphoma, which cause which interfere the production of the RBCs. And next, it also can cause suppression to the bone marrow in case of chronic inflammation, and also when there is toxic and also medication and radiation.
Dahiyah. Classifying leukemia and lymphoma as bone malignancy is not that correct lah.
Oh, yes. It's a hematological actually. Sorry that I just refer to there's a PET case references. Basically, it hematological malignancy that can involve the bone marrow. Okay, I will correct later. Okay, next is bone marrow failure, and this is commonly found in early onset of anemia, such as in diamond black fan syndrome, parvovirus B19 infection, transient erythroblastopenia of childhood, and Fanconi anemia, which all of this can cause red cell aplasia. So for diamond black fan syndrome, it is a congenital bone marrow failure syndrome in childhood, and commonly it represented its onset of syndromic features. And parvovirus B19 infection, usually it only can affect the child with inherited hemolytic disorder, inherited hemolytic anemia, but not to healthy children. Okay, transient erythroblastopenia. Usually, it is unknown etiology, but usually following a viral illnesses, and usually it's self-limiting. And Fanconi anemia is also a rare condition. It's autosomal recessive disorder, which can cause aplastic anemia. Okay, the next pathology is when there is increased destruction of the RBCs, which at one point the body cannot compensate to produce RBCs and can cause anemia. So for increased distraction, it can be understood by external factors or internal factors. For external factors, when it involves the mechanical valve problem or any issues that disrupt the hemostasis of the blood vessels and cause mechanical trauma, which is in the disseminated intravascular coagulopathy, the IVC, and also hemolytic uremic syndrome. It can also be due to immune reaction, which the cause can be because of transfusion reactions, autoimmune hemolytic anemia, and also hemolytic disease of newborn, such as ABO incompatibility or Rhesus disease. So for internal factors, we know that much more deeper, go into internal structures of the RBC itself. So if there is any abnormalities of the membrane, such as inheritary spherocytosis, it cause the destruction of RBC. And also hemoglobinopathies, such as in thalassemia and sickle cell disease. There is increase in the destruction because the shape itself prone to first oxidation stress, and also when they go through they cannot pass through the microcirculation, so it causes destruction, increase in destruction. And last one is the enzyme disorder, such as in G6PD. Increase in restriction also can be as a hemolysis process. Okay, the last one is blood loss. So blood loss for fetal maternal bleeding, which can cause neonatal anemia, and we had discussed it before in the previous PBS. So other causes of blood loss such as chronic gastrointestinal blood loss, such as in Meckel diverticulum, inflammatory bowel disease, peptic ulcer disease. Also in acute cases like acute blood loss in surgery or trauma. Patients with inherited bleeding disorder also have high risk, such as bone Willebrand disease and also hemophilia. And we have to also consider the child for girls who had reached menarche can present with menorrhagia.
Okay, wait, Dahlia. Okay, let me ask the others. Can you tell me one simple test to check for presence of fetal maternal bleeding? Any test that we can do to check for presence of fetal maternal bleeding? Let me look at names. Kat my screen ni bawah nama Dahlia is Fitria. Sudah.
Said,
Fitria, any idea? One simple test.
Ni lab test ke ataupun imaging ke?
Lab test.
Lab test. Rasa FBC dah cukup.
Kita nak if you do FBC you can only see anemia. But to test whether there is fetal maternal hemorrhage or not, fetal maternal bleeding.
Any coagulation profile?
You can only see baby punya. Okay.
Tak sure, doktor.
Pernah dengar Kleihauer test tak? Kleihauer test. K-L-E-I-H-A-U-E-R. Dahlia akan represent sikit ke tak ada?
nak tunjuk?
Ada mention pasal Kleihauer test.
Saya tak cover pasal tu.
So basically fetal maternal bleeding ni what we can do is we do Kleihauer test. Cuma Kleihauer test ni we test maternal punya blood. So kita ambil mother punya blood sample lah. So it can show us whether is there any fetal maternal bleeding or not. So isunya is bila ada fetal maternal bleeding, mother will produce antibody against baby punya blood lah. So and this causes blood loss lah. So fetal maternal bleeding. Okay, fine, proceed.
Okay, so this is a summary. So understanding the physiology can really help us, like for example, in where there is an impact in red cell production. Okay. When there is impact in red cell production, we know that when there is anemia, our body cannot compensate because there is a problem at the initial point of the red blood cell production. So it will cause reticulocyte low. So usually we can found reticulocyte count is low in this set of disease under the impact production. However, in the hemolysis, usually the reticulocyte can be normal. Okay, so for the age variation, so for children, since birth to 3 months old, usually it can be due to physiological anemia and also pathological anemia, and we have already discussed it in the previous PBS. So I'm focusing on the next age, which is starting from 3 to 6 months old. Rarely we can find IDA at this point of age because usually there will be exclusive breastfeeding, and usually the breast milk is already adequate to give the iron supply. And at this point of age, we can also think of the hemoglobinopathy. However, it's also usually at more than 6 months old to diagnose thalassemia. And for toddler, children, and adolescent, more likely the causes of anemia is IDA.
Wait, back. Okay, so for birth, for newborn, there are several other causes that is actually important. Things like anemia of prematurity. So that one is very important as well. I'm not sure whether it's covered or not. So anemia prematurity. Second is another important factor. Okay, if anyone can guess what it is, important cause for anemia in newborn, especially premature newborns, small IUGR newborns, those with prolonged admission to an ICU, those with central lines, those with arterial lines.
Is
So
it
anyway,
because the blood sampling procedure?
yes, iatrogenic. So iatrogenic is one of the major cause for anemia, especially in newborns. Okay, all right.
Okay, so for the sex variation, so for boys, we should also think of the X-linked diseases such as G6PD or X-linked sideroblastic anemia. And for girls, usually they are associated with autoimmune disease and also excessive menses. For
Wait,
race and
can GCPD occur in girls?
Is it? Can I try?
Yes.
Is it? I think it's possible, but not purely based on the concept of lionization of the of the genes.
Yes. So there are dua possibility how girls can get GCPD. The first one, if mother is GCPD and father is GCPD as well. So kalau both GCPD, so there is a chance of the child getting, most likely the child will get GCPD deficiency lah, kan? Kalau father GCPD deficient, mother as well GCPD deficient, so obviously children tu boleh dapat lah, yang girl tu. The other one is lionization. So lionization is another concept. So where usually your X-link ni usually only one that is prominent, but in lionization, the mutant X gene is the one that is prominent and shows this GCPD deficiency phenomenon. Okay, all right, good.
so how about case of like Turner syndrome when there is only one XO? Can also they get
So GCPD ni X-link recessive ke X-link dominant?
Recessive.
Dia X-link recessive. Yes. So kalau dia X-link recessive depends on how many X dia ada, kan? So who the child gets? If the X yang ada tu is the X yang mutant X, so the child will present with GCPD deficient.
right?
Alright.
So for race and ethnicity, so commonly you can see hemoglobin S and C in the Black and Hispanic population, but maybe more related to us is at the Southeast Asian and Mediterranean. Southeast Asian usually can we can have thalassemia syndromes and G6PD deficiencies more commonly in the Jews, Filipinos, Greek Sardinian Kurds and Black populations. Okay, so we go to the clinical part for the history taking. So start off with the history of presenting illness. So what are the complaint that the child or the mother will tell us. So usually it can vary from mild to severe presentation. And usually when it's mild, the patient usually just asymptomatic and not very noticeable. And also in the underlying chronic diseases like anemia and chronic disease, the symptom might be less profound and less significant. So all common symptoms of anemia can be lethargic, pale, irritability, such as in infants, they may become like in this presentation, decreased exercise tolerance and poor oral intake. And in severe anemia, like acute blood loss, for example, they can have headache, visual blurriness, palpitation, and also dizziness. So we also have to ask about the symptoms of hemolysis, such as there is a changes in urine color, such as dark urine, or any changes in the sclera and yellow discoloration. And also we have to ask about the bleeding symptoms, such as in gastrointestinal bleeding. We have to ask about the stool color, there is any blood noted in the stool, or history of bowel symptoms such as abdominal pain, vomiting, diarrhea, and so on. And also bleeding tendency like epistaxis, mucosal bleed. We want to know if there is any underlying bleeding disorders and menstrual history for girls. Any specific symptoms such as fever, also we have to ask because there is anemia due to following acute viral illness, or maybe it also can be clue of maybe like increased restriction in the IVC and so on. With adenopathy, when there is any malignant involvement, infiltration, and also abdominal enlargement. Also, it can be as even throughout malignancy, any infection or thalassemia itself. Okay, so other history. For past medical history, we want to know any previous episodes of anemia. So if that's what happened, we have to know what is the diagnosis during that time, the duration, and also the therapy that the child have. And also any systemic disorders such as autoimmune, chronic diseases, and also history of transfusion. Okay, also ask about the past drug and allergic history, such as in the G6PD, we want to be aware of the any oxygen drugs, or any cytotoxic or chemotherapeutic agents, and also any supplements. Okay, for birth history, it's very important. We want to know the gestational age, like Dr. said previously. Prematurity also have prematurity is a risk of having anemia and also IDA itself. And then maternal anemia during pregnancy, also presence of iron deficiency during the pregnancy. Any history of jaundice and anemia in the newborn. Actually, we know that all babies have been screened for G6PD, so we just can ask the mother how about the result of the G6PD. Okay, then for developmental history, we want to know is the child have reached the age developmental milestone and the growth parameters, because it can be affected in IDA. Okay, and for family history, we want to know any family history of jaundice, splenomegaly, and breathing problem, and also any traveling history like malaria and in the endemic countries lah, like malaria and tuberculosis, because infection also can cause anemia. So this is the important part for nutritional history. So because of the commonest cause of IDA and anemia in childhood is iron deficiency. So for infants, we want to know the type of formula milk, and then we have to ask does the child currently being on cow's milk, which is non-formula milk, like cow's milk, goat's milk, or soy milk, because there will be lack of iron. And late weaning, such as when there's more, the child after 6 months, does he or she have sufficient iron-rich complementary foods? So we have to ask the mother. And then for toddlers and children, we want to know about the excessive intakes of cow's milk, which is like about 20 ounces per day. Any eating habit like picky eater, because maybe it can cause lack of iron rich food supplement for the child, and also any strange desire to eat non-food items such as pica or pecophagia, which is can be one of the presentation in IDA. So you can just read what I right here about the source of iron and also the dietary sources. So next, okay, for physical examination. So in general examination, I want to look the general look of the patient. Is it patient in short stature, normal child, and so on. The appearance and also dysmorphic features. So for this time, we want to see any thalassemic faces like frontal bossing, prominence mala, and maxillary boots. Okay, so and look for the child's alert and consciousness, and check for the eye, any signs of conjunctival pallor. And usually clinical pallor can be appreciated when the hemoglobin less than 7 grams per deciliter. Scleral jaundice, and we can also check other site of pallor, such as in the capillary beds in palms and also the nail beds. Okay, and then check for the mouth for angular stomatitis in IDA and also the hydration status. And then check for the lymph node involvement and also the tonsils if there is any signs of infection. And then check for the hand. When there's acute blood loss, we want to know if there is any signs of poor perfusion, like cold hands, or I forgot to mention about the CRT level, and also spoon nails in the IDA. And it's important to check for the vital signs because anemia can cause tachycardia and also tachypnea. Okay, and then check for any skin manifestation like petechiae or bruising, which can lead to any bleeding disorders. And in severe anemia, patient can have murmur and gallop rhythm during cardiovascular examination. And also, we have to look for hepatosplenomegaly at the abdomen.
Okay. Wait. One question. If you have a child, newborn, if you have a newborn born by forceps delivery, and no, let's say born by vacuum, venous assisted delivery, born by vacuum, and then nurses call saying, "Hey, the child looks pale." Anything that you want to see, anything that you may think, the reason. Child born by vacuum delivery. And
Kalau
then
hematoma, Prof, ada?
About
okay.
subgaleal hemorrhage.
Yes. So subgaleal hemorrhage or subaponeurotic hemorrhage. So I think more people in Malaysia called it as subaponeurotic hemorrhage. So subaponeurotic hemorrhage or subgaleal hemorrhage. So it's basically the same thing. So bleeding in the scalp. So bleeding in the scalp ni ada berapa jenis? Dia ada satu subgaleal atau subaponeurotic hemorrhage ni. Lagi apa lagi? Cephalohematoma. So how to differentiate between cephalohematoma and subaponeurotic hemorrhage?
Whether it extend beyond the suture line.
Why?
Because
Kenapa cephalohematoma doesn't cross the suture lines?
Because the layer of the area of involvement is external to the periosteum.
So because cephalohematoma is below the periosteum. So cephalohematoma is bleeding in between the bone and the periosteum. So that is where the bleeding occurs. So bleeding tu banyak tapi it's confined based on the periosteum. Tapi aponeurosis ni, below aponeurosis is usually satu venous bleeding. So venous bleeding susah nak vasoconstrict. So bleeding tu lagi susah nak berhenti. The secondly is because it's a huge potential space. This area, this subaponeurotic area ni, below the loose connective tissue ni, is connecting to your whole body daripada head to toe. So bleeding, bila ada bleeding, that's a potential space, the whole body. I've seen the baby where the bleeding from the head, it goes straight even to the buttock. So it's very severe bleeding. Okay, so always think. So especially in newborn, another thing is head and neck examination. Look for bulging. And then kalau the SAH apa? You akan rasa dia bulging and then dia apa? Bila you tekan, you boleh nampak dia punya what call that masa tu. Fluctuant. Yep, dia fluctuant, dia tender and dia cross the suture midline. Okay, alright, proceed.
So this is addition. When we suspect there is a syndrome features, we want to complete all the syndrome findings in Blackman-Diaphragm syndrome, Blackman-Diaphragm anemia, and also Fanconi anemia. Okay, so next we move to the investigation. So how we approach child with anemia. So the first and foremost investigation that we have to do is full blood count. So because there's a lot of information that we can extract from the full blood count, such as we want to know the hemoglobin level, we can see the severity, and also you can know the type of anemia, which is by looking at the MCV value. So we want to know, is it microcytic, macrocytic, or normocytic anemia? And others red cell lines information like MCHC, RDW, the distribution, and also the reticulocyte counts. Okay, and also we want to know under the FBC, which is the white cell count and also the platelet level. So this is a bit of summary when we see the patient. So this is anemia. We want to look, is it occurred with jaundice or no jaundice? So because when it is jaundice, so it means that hemolysis is more on top of the list of our differential diagnosis. But if there's no jaundice, means that there's less likely the hemolysis to be occur. So we can stand for LFT and also LDH to see the distraction level and also the bilirubin. I think jaundice will be more presented by my colleagues after this. So what we can see here, following if the patient come with jaundice, means like there is an hemolysis occur. So there is a hemolysis workup, such as we can order for peripheral blood films. We can see the hemolysis type, and then hemoglobin analysis and BFMP. Hemoglobin analysis pertain to thalassemia, BFMP for malaria. And when the patient presented with no hepatosplenomegaly, we can send for disease speed screening and Crohn's test. But I want to say all the investigation have to be individualized. We should not order all together without having any thinking process for what happened to your patient. So
Must use
when
your brain lah maknanya. If you order any test, you must use your brain. Before
yes,
before it goes from your mouth or from your fingers, you need to use your brain first.
yeah, true. Okay. So peripheral blood film, for example, usually we only send when we suspect a case of pregnancy, hemoglobinopathy or hemolysis. So when there is no jaundice, so we further look our patient if he or she presented with hepatosplenomegaly or without hepatosplenomegaly. So if there's no hepatosplenomegaly, maybe most common is not genetic causes like nutritional, hormonal, or marrow failure and blood loss. So we could send for thyroid function test because hypothyroid can cause reduction in the erythropoietin production. Iron studies, but for iron studies, for what I know, for what I read from up to date, it said that we rarely order for children less than 2 years old if the patient already suggestive of IDA from history itself. And then we should only do iron study when we doubt the diagnosis or when the patient does not respond to our therapy. Okay, and then followed by other tests like serum bitter and folate when we suspect of megaloblastic anemia and stool for occult blood. Okay, for infiltrative causes, we will order for bone marrow expression and trophine biopsy. Okay, so this, if I zoom, can you all see this? Yes, okay. So this is approach, kind of okay, it's easy for me because so we can follow the algorithm. When the patient come with low hemoglobin, first we see if other cell line affected. So only involve red blood cell or also platelet and also white cell count affected. So if there is other cell line affected, we see the MCV value. So if the MCV value is low, which is microcytic anemia, there is a list of the causes and also normal and high MCV. And normally in child, the common causes of anemia is microcytic anemia. So I'll be focusing on more about this. So what is the commonest causes of microcytic anemia? There is a mnemonic. I see the little cell. So I see the little cell. I is IDA. S is sideroblastic anemia. Thalassemia, T, N, leg toxicity, and C, anemia of chronic diseases. So we have reduced some space in our brain, right? Okay, and the other investigation following the microcytic or normocytic because there are more causes for normocytic and also microcytic anemia. Okay. So for FBC itself, like I said before, it gives more information and we can differentiate between the microcytic anemia causes. So this is, I think you can refer it back later. So this is the table in the Nelson which differentiate the findings in IDA, thalassemia and anemia of chronic disease in FBC and also the iron studies. and I added some values, which is the Menzel index, which we usually can help us to differentiate between IDA and thalassemia also. So a bit of revision, right? Okay, this is
Just one question. So Menzel index and RDW is almost the same. It's almost the same in terms of the use where we can differentiate between IDA and thalassemia. So why is it that okay? What is RDW?
RDW is the red cell distribution rate, which okay. So you want to know the morphology of the RBCs. So in IDA, usually there will be high RDW because the size of the RBC, it depends on the iron stores at that point of production. So it will become varies in size. So there is high width of distribution. However, high distribution width, sorry. However, in thalassemia, the red cell usually generally is small. So the RDW is less.
Yeah, so that's true. So if you understand that, so RDW is just the measure of anisopoikilocytosis. So in iron deficiency, definitely there's more anisopoikilocytosis because the production depended on the current storage of iron. So obviously the storage iron will be fluctuate. So this is why will be higher RDW and higher Menzel index as well. So this has come out in exam before. I think was it last exam ke something keluar. Exactly the same thing that I asked just now. Proceed.
Okay, next. Okay. Okay. So this is just example of peripheral blood smear. I think last we see in our class in MS, right? So what we can see in this first picture, there's a reference point, which is the arrow, which is our lymphocyte. So we can compare the size of red blood cell compared to the lymphocyte, which is much more smaller. So it can be found in the microcytic anemia and in the microcytic type of cell. And next we look at the central part of the cell. It's large in the central panel is larger compared to normal red blood cell. It should not be more than 1/3 of the cell. So this is the example of microcytic hypochromic microcytic anemia, which usually can be found in hello. What is the diagnosis?
IDA.
Yes. Why? Also, we can appreciate there is a pencil-shaped cell. Okay. So next, this peripheral blood smear showing a very dense cell, small, very spherical in shape, and there is no centropetal. So what is most likely diagnosis for this? It is hereditary spherocytosis. Also can be found in hemolytic anemia. So there is no centropetal. The red blood is very dense. Okay, next one. Okay, I just a bit faster. So ini is can be seen in B12 deficiency. We can appreciate the size of the red blood cell is very large. And the last one, can you see the arrow showing the size like being beaten, right? So it is bite-like cell, which can be found in G6PD. And the second picture showing the Heinz bodies. Okay, so this is HB.
Wait. I just wanna say, this sort of pictures pernah masuk OSCE. I think exactly last exam. I think the question was about bite cell. So bite cell, Heinz body, blister cells. So you need to know a bit lah macam mana rupa dia. It has come out in OSCE. And obviously in your time, yang mana it will be very difficult to conduct clinical exam. You would expect more to come out from other type of theory exam. So kena tengok sikit lah.
Okay, thank you, Doctor. Okay, this is HB electrophoresis, which is very helpful to help diagnosing hemoglobinopathies, such as thalassemia, HBS, sickle cell disease. So it's showing the normal HB in newborn and adult, and we can see there is the differences in each type of the thalassemia, like thalassemia trait and thalassemia major. So okay. The last one is direct chrome test, which can be helpful to diagnose with immune hemolytic anemias. So in this direct Coombs test, usually we take the patient blood sample and we add Coombs reagent. The Coombs reagent contains the anti-human antibodies. So as patient who have immune hemolytic anemia, they have antibodies attached to their red blood cell. So when the Coombs reagent, the anti-human antibodies being inserted, it will clump and agglutinate all the antibodies. So we can see there is precipitation showing positive result. Okay, last one, management. Okay, I just include the most commonest causes of anemia in childhood, which is IDA. So at this point, we have to know that what is the most likely causes of IDA in our patient, which is include inadequate intake, malabsorption, blood loss, or worm infestation. So generally, for management, there is a role of non-pharmacotherapy, which is nutritional counseling. But usually it helps in prevention. But once IDA is confirmed, the nutrition is not adequate enough to replenish the iron store. So we have to start with oral iron therapy. So for this under nutritional, we have to encourage the child to, if the child is still breastfed, we encourage breastfeeding because breast milk is already sufficient to supply iron store. But if there is prematurity, we can add iron supplements at the 2 weeks of age. For child having problem with breastfeeding or partially breastfed infants, we should give the fortified iron formula. And at 6 months of age, encourage for weaning, which is complementary food containing iron-rich food and vitamin C. And we have to also advise the child at the age of 1 to 5 years old who is bottle milk feeding should not consume more than 20 ounce milk per day. And because at this point of age, they have to have a diet complementary like iron-rich diet, red meat, liver, beans, and so on. Okay. Next one, this is the therapy, pharmacological treatment, iron oral therapy. So the dosage 3 to 6 milligram. The sources that I take is they give 2 times per day. But in Nelson, it can be divided into 3 doses. Maybe doctor can add more about it. So after we give the oral iron therapy, we continue the therapy after hemoglobin level restored to normal for 6 to 8 weeks. And then there is a preparation in syrup formation or tablet formation. And then we have to advise the mother for GI side effects such as epigastric discomfort, nausea, and so on. And encouraged to take the oral iron therapy with ascorbic acid. And we have to repeat the investigation after 1 month. Okay, and then if there is a problem for oral therapy, we can start offer parenteral iron. And currently there is only one preparation that be approved, which is iron dextrane. And we have to be careful with the allergic reaction in parenteral iron. And last one is blood transfusion, but generally it's not required in iron deficiency anemia unless the patient came with overt cardiac decompensation as severely symptomatic. Okay, this is what we want to consider when the patient is failed to the oral iron therapy, such as non-compliance, the dosage, maybe there is the underlying blood loss, there is absorption, malabsorption, or incorrect diagnosis, or maybe there is the underlying rare conditions that prevent the absorption. Okay, the next one is thalassemia. So for management of thalassemia, there is 5 management, which is start with blood transfusion, iron chelation, splenectomy, definitive, and also diet. So this is for blood transfusion is the main therapy in thalassemia, and we give this transfusion based on the type of the thalassemia. So for thalassemia major, we should start transfuse when the diagnosis is confirmed, when the hemoglobin less than 7, on 2 occasions more than 2 weeks apart. For thalassemia intermedia, we look at the hemoglobin level less than 8, we start transfuse. And then for alpha thalassemia, we only transfuse when the patient HB level below 7, or maybe they presented with symptomatic chronic anemia. And also we start transfusing when the patient already have the bone changes and large spleen and also paraspinal mass. And you can just refer all the others consideration like interval transfusion within target and test. Okay. So ion chelation therapy, when to start the ion chelation therapy? When the patient have already reached 2 years old, when the serum ferritin is high, and also when the need required transfusion more than 10 to 20 times. So the agents for ion chelation can give deferoxamine, which is the best, and we have to beware of the side effect of each of the agents. So I think you can just read it. And the oral preparation, like deferopiron and deferoxamine is also available. But deferopiron, we should not give as monotherapy. Okay, this is splenectomy. Okay, so the next mention, splenectomy is when indicated when the patient came with hypersplenism, defined as presence of splenomegaly, thrombocytopenia with increased risk of bleeding, leukopenia with increases of infection, or when the patient have very large spleen and associated with heaviness and erythritidity, showing there is mass effect. And the last one, when the patient required blood transfusion more than 200 milligram per kg per cell. Okay, for bone marrow, it is a definitive treatment. So it is the best because patient can live normally. However, it required only when there is a HLA compatible sibling marrow donor. And then how to know the best time, best stage to do the BMT, we can use the Pesaro risk group. So this is the Pesaro classification, where there is 3 risk factor that we should consider, which is the presence of hepatomegaly, liver fibrosis, and ion chelation therapy. So when all 3 risk factor is favorable, which is class 1, so that is the best stage to do the BMT. Okay, last one is diet and supplementation for thalassemia. So we encourage for them to eat nasi goreng because it has palm oil and vitamin E as antioxidant for them. So encourage dairy product milk because it can compensate with the iron for absorption, so less likely to have iron overload. And drink tea 30 minutes before lunch to reduce the iron absorption at intestine. Iron folate, and also avoid iron rich food. So basically it's to help them to prevent as a prevention to have chronic iron overload. So these are my references. Is there any questions?
Okay, questions to the presenter before I ask you question.
I have a question actually. With regards to in the textbook mentioned that in beta thalassemia we will have ineffective erythropoiesis because of the premature destruction of the erythroid precursors, and then we will not see a reticulocytosis. But I couldn't find the description, similar description in alpha thalassemia. So in alpha thalassemia, can we expect a reticulocytosis to occur, or is it like ineffective erythropoiesis as the case of beta?
It's similar. It will be similar.
Okay, thank you, Doctor.
It will be similar, but the thing is, you need to remember, alpha thalassemia. It depends on the it depends on the genes as well. Because alpha thalassemia, some of them are very severe, and if you have like buds, is it? You can even it's not even compatible with life, isn't it? So it can be more severe, it can be less severe.
Thank you, Doctor.
Okay, my question. Okay, fine.
Ada saya pula ada question.
Okay, my question. My question to you guys. Okay, you have a child, you have a boy coming to the ward with jaundice. Coming to the ward with anemia of HP, let's say 6 or 5. There's jaundice in the eyes, there is dark colored urine, and there's a history of eating nuts the day before. What do you think is the diagnosis?
G6PD.
Okay. Okay. My question is, would you do GCPD test on this child? How about that? Would you test? Would you send GCPD test?
I think we would just for confirmation sake, just for documentation. I mean like macam there's a proof lah, but clinically it's already suggestive of GCPD.
No, doctor, because the erythrocyte already been destroyed, so we cannot assess the exact level of enzyme.
Okay, so basically, if you do GCPD test, most of the hospitals, even actually most centers, they don't usually test the enzyme. What they do is a immunofluorescent test. So basically, the problem with GCPD deficiency is GCPD is the enzyme. The disease is GCPD deficient. So it's just that they do this children, they still have GCPD, they still have the enzyme, but it is deficient. So when hemolysis occurs, the problem is the RBC that hemolyze are those with GCPD, those that are deficient in GCPD. The remaining RBCs are those with normal GCPD enzyme. So if you test them during this hemolysis period, you will have a false negative. So if you test, it will become normal. Why? Because all the RBCs that are deficient in GCPD, they are hemolyzed. They dah pecah-pecah. You won't see. So the ones that you will see when you do the immunofluorescent test, you will see other normal RBCs with adequate GCPD enzyme. Okay, so this is one thing that you need to clear. Or sometimes you will see this sort of patient sibuk nak buat test. Kan, bila you test, sometimes you'll be false negative and then you will feel comfortable. Ni nak kena remember. I have GCPD deficient.
Doctor, in that case, will blood smear will be helpful?
Full blood picture you will only see Heinz bodies, bite cell and things. So definitely it will be helpful, but sometimes it is not useful for diagnosis. Unless if you see Heinz bodies macam tu lah. Kan? But sometimes it's not, you won't see them all the time. Okay. Alright. Any other question?
Alright. Okay. Actually, we for all my colleagues, we will prepare online games for you later. So make sure you can remember all my points. So is there no more question? I pass to the next presenter.
Dahlia.
Oh yes, apa tu?
Okay. Nak tanya, tadi kan for IDA, you say that only in overt, overt cardiac decomposition or one more indication that we need to transfuse the patient. What if patient with IDA come with low hemoglobin? Means that do you need to transfuse them also? Maksudnya in low level of HB, severe.
Is it just like what I mentioned before. So the best management for patient who are already suspicious and confirmed IDA is oral iron therapy. That is the first line of management, because usually they will respond very well, very rapid to that therapy. But if initial presentation like in overt cardiac decompensation, very maybe presenter with shock or cardiac involvement lah macam tadi tu. So maybe we could think of blood transfusion. But what I read in one of the website that it means, it said that it will not really helpful. Just we can apa nama dia? Sebab kita nak replenish iron store tu. So basically we give iron. So blood transfusion tu just untuk macam stabilization.
Okay, thank you.
Blood transfusion is just an acute measure. It's just temporary measures. It won't solve the problem because the problem is iron deficiency. It's not RBC deficiency. Okay, one thing I need you guys to remember is if you need to transfuse, berapa banyak you nak transfuse? 10 mils per kilo, 15 mils per kilo, 20 mils per kilo?
Depends on the target of the hemoglobin.
Okay, depend on target something.
Apa
But
tak ingat.
Dahiyah was trying to say something.
Saya cari juga tu sebab tapi saya tak jumpa sebab memang mostly kata not indicated.
Not about IDA.
IDA.
Basically, it's about anything. JCPD ke apa. If you have a child with anemia, if you want to transfuse, how much would you transfuse?
Based on the body weight.
So basically, if the child is thalassemia, there's a calculation kan? Kan ada ke? Target ni times 4 apa benda kan? So because usually 4 tu, in Dahlia punya presentation dia ada slide dia ada formula that I saw your formula.
Ya,
It's
ada
4.
sekejap saya.
So 4 is the basically is a constant. 4 tu dia change. Sebenarnya kat Malaysia kita letak 4 ni because generally Malaysia punya population how many mils of blood tu equals to dia punya number is 4 lah. Tapi in certain population it may be higher, it may be 4.5. In certain population it may be a bit lower, 3.5 macam tu. Tapi generally in Malaysia kita ambil 4 untuk dia punya calculation.
Maksudnya kita ambil sama dengan thalassemia punya guideline ke?
Maknanya 4 unit ni akan dapat 1 gram naik contoh macam tu. Okay, the other point is you need to remember for chronic anemias, those with chronic anemias, you cannot transfuse banyak sekali. Contohnya patient tu datang dengan HB of 4. You tak boleh immediately transfuse 10 mils per kilo, 20 mils per kilo. Tak boleh. Kenapa?
So body dia dah already compensation.
Yes, and then you constraint is on the heart. Because if you transfuse too much at the same time, you may cause heart failure. So in this sort of patient, usually kalau patient yang chronic anemia or those presenting with HB less than 5, those presenting HB less than 5 or chronic anemia, usually the first transfusion we give 5 mils per kilo, and then next transfusion we give another 5 mils per kilo, and then next transfusion we give 10 mils per kilo. Lepas tu baru kita tengok, kita build up dia punya hemoglobin gradually, because the strain is on the heart. So kita kena transfuse gradually. This I want you to remember, because why? Because I've seen people they plan nak transfuse, sebab contoh patient datang HB 3 cepat-cepat nak transfuse, and then the problem is the child suddenly become tachypneic and go into heart failure sebab kita cepat sangat, kita rush nak kejar. Unless kalau the anemia is because of acute loss. Contohnya macam I've seen one patient, one child dia ada arterial line, peripheral arterial line dekat radial artery dia. And then somehow macam mana tercabut bang dia. Line dia still ada. Dia still connected dekat radial artery, tapi kat hujung dia line tu tercabut. So bleeding memancut-mancut daripada radial artery. So HB drop banyak. So in this sort of case, you need to transfuse fast because this is an acute blood loss. So blood loss, you replace blood loss immediately as amount of the blood that is lost. Sama juga dengan subaponeurotic hemorrhage. So we replace based on the loss. Tapi kalau chronic, kita replace slowly. Okay, fine. Nampak dah ni. Let's go to the next presentation. So next presenter.
Okay. I am the next presenter. First, I'm sorry, doctor, that you didn't get my slide. So okay.
I found masuk dalam spam. Baru jumpa.
Oh ya ke? Oh, baik. Okay. So I'm gonna ask siapa? Aklan Aklan project my slide because my internet connection quite bad. So I'm so sorry about that, and sorry for the interference of the sound. I don't know, there is a construction work behind me. Okay, so the next presentation, I will talk about the child with easy bruising. Can make a full slide? Okay. So the title would be Child with Easy Bruising. So my name is Nadira binti Azmi. The outline for my presentation, I will talk about the definition, pathophysiology, etiology, history, physical examination, investigation, and common cases. So, and next, okay, based on this picture, there is a bruises. You can see around the right eye of this girl. So we might wonder whether the bruises is due to some blood problem or maybe due to abuse. So even though this girl is smiling, but we cannot exclude that the reason due to the physical abuse. Okay, next one. Next slide. Okay. So moving on to the definition of the bruises itself. Actually, the bruise, if we talk about bruises, it means ecchymosis. So ecchymosis, by definition in from up to date, it was said that ecchymosis is a collection of blood beneath the skin that resulted from the extravasation of blood from surrounding vessel. Okay, and easy bruising are defined as bruising without any history of trauma, or if the bruising are due to the minor trauma, it doesn't cause any problem in the past. Okay, and then based on the bleeding assessment tool by International Society of Thrombosis and Hemostasis, the significant cutaneous symptom of bleeding is when there at least five bruises means more than 1 centimeter in exposed area. Okay, that's considered as significant bruises. Okay, moving on to the next slide. I will just remind us back regarding the normal physiology of hemostasis. So hemostasis is the active process that clot the blood whenever there is a vessel injury, and it also limits the clot size. So it will not like overclotting occur at the site of injury. This definition is based on the Nelson, and there is a 5 main component inside the hemostasis, which is a coagulation factor, which mainly produced by the liver in inactive form. So we need to activate the we need to initiate the coagulation to for the coagulation factor to be activated. And then there's also anticoagulant which oppose the act of procoagulant factor. This anticoagulant can be found in plasma or bound to the endothelium. It prevents widespread of coagulation through the body once the coagulation is initiated. And the example of anticoagulant would be antithrombin 3, protein C, protein S, and tissue factor plasma inhibitor. Okay, other than that, the fibrolytic system also the main component inside the hemostasis, which it helps in limiting the fibrin deposition at the site of injury. Do not forget there is also plasma which aggregate at the site of vessel injury to form the primary hemostatic plaque. And then our blood vessel are also important in initiate and limiting the coagulation cascade itself. So when there is an intact vascular endothelium, the anticoagulant will have more actions such as prostaglandin and nitric oxide, since they promote vasodilatation and inhibit platelet aggregation. But if there is a damage at the vascular endothelium, there will be release of tissue factor and other type of procoagulant. Okay. All right. This is the simplified diagram or of how the hemostasis actually take place. So if you see from the top, is there when there is a vessel injury, first once being exposed, our blood vessel will go immediately to vessel constriction, and this vessel constriction will reduce blood flow to the site of injury and eventually help in the formation of primary hemostatic plaque. Other than that, when there is a vessel injury, there will be subendothelial matrix exposure. This included collagen and tissue factor. So collagen will help addition of platelet into the site of injury, while tissue factor will go and bind to the coagulation factor 7 to initiate the blood coagulation cascade. Okay. Once there is a platelet addition at the site of injury, it will get activated when the von Willebrand factor form a complex with glycoprotein 1B. Okay. When the activation of platelet, we secrete granules and also secret granules, and there is also release of thrombosin A2, ADP, serotonin, and platelet phospholipid. So once there is activation of platelet, it will start to aggregate and form primary hemostatic plaque. So bear in mind the primary hemostatic plaque is not that stable, so we still need fibrin to make it more stable plaque. Okay, so from where we need to get the fibrin? The fibrin are resulted from the blood coagulation cascade. Okay, and then the next diagram. All right. Okay, this diagram just explain further what I already mentioned before. I just like to put this diagram because it look nice. Okay, moving on to the next slide. Okay, so next slide. Okay, this one is the detail. I'm going to talk about how the stable hemostatic plaque formation. So based on the intrinsic pathway I already mentioned before and extrinsic pathway, we need to know the function of thrombin. Okay, there is three function of thrombin. Actually, the thrombin function in helping aggregation of platelet. It activate the factor 5, 8, 9, and 13, and it also help in conversion of fibrinogen into the fibrin. Okay, when there is a stable fibrin platelet platform, the anticoagulant will start to work. Okay, thrombin, once it encounter the intact endothelium, it will start to bind to the thrombomodulin and form a complex. This complex will convert the protein C into activated protein C. With the help of cofactor protein S, it will start proteinase and inactivate factor 5 and factor 13. As you can see in the diagram, when you cross out the activated factor 5 and factor 13, there will be no there will be no conversion of prothrombin to thrombin. So this will stop the fibrin formation. Okay. Okay. Lastly, when they detect that the stable plaques already formed, fibrinolytic system will start to play its role. Plasminogen will be converted into plasmin and degrade the fibrin clot, which produce fibrin degradation product. Okay, lastly, the role of blood flow around the site of injury also crucial, as the blood flow will bring all the blood back to the liver. Okay, this circulation will help to remove the complexes that already being activated back to the liver to be degraded. Okay, and then the new procoagulant and anticoagulant will be synthesized to maintain back the hemostasis. Okay, next slide. All right. I hope you guys are okay with that explanation, and I hope you still have smile on your face. Okay, moving on to the next slide. Okay, all right. So this is the etiology. How the bleeding occur. It can be divided into the three main causes. The cause may be due to the platelet itself, or there is a problem in the coagulation process, or there is a disorder of blood vessel and surrounding tissue. Okay, according to the Nelson, the cause of bleeding they divided into hematologic and vascular non-hematologic. Similar to the causes inside the box. Okay, for hematology, they divide it into thrombocytopenia and coagulopathy. Under the thrombocytopenia, there is a primary and secondary thrombocytopenia, while coagulopathy, there is primary and secondary coagulopathy. So next, I will only talk about the ITP and hemophilia only. All right. So moving on. Okay. So the history, first, it is very important for us to differentiate whether the bruises actually a suspicious bruises or a bruises secondary to the blood disorder. So once we acknowledge the age of the patient, for example, in units, in hemophilia patient, 20% of the patient has bleeding during neonatal period. And usually the presentation would be in form of intracranial hemorrhage or bleeding after circumcision. I think bleeding after circumcision occur once the patient the age at the school age. I don't think we circumcise neonates. And
Okay, wait. Do you know what is the problem? Do you know why? Why in this? I think you got from somewhere, isn't it? Mentioned after circumcision. Do you know why? Okay. What is the sunnah for circumcision? So circumcision for Muslim is wajib, isn't it? It's wajib. It's for male is wajib, is fardu ain for all male. For female, there's khilaf about circumcision. Okay, fine. What is the sunnah? Circumcision is wajib, but the sunnah for circumcision, what does the Prophet teaches us?
Once being born,
Okay, the sunnah for circumcision is you circumcise a child by 7 days old, day 7 of life. By day 7 of life, there's hadith about this. Day 7 of life, you give the child a name and you circumcise the child. So that is the sunnah. And that is actually practiced all over the world. If you go to Middle East country, if you go to Arab countries, so they all circumcise their children in the newborn period within the first 3 months, the first 2 weeks ideally. Even if you go to UK, so I've lived in the UK, so even in UK they circumcise their child within the first 7 days. Ideally is the first 3 months. Only in Malaysia we circumcise children when 7, 8, 9, 10, 11, 12 years old. Why? Because circumcision here is more cultural. We don't follow sunnah. We don't read sunnah. That's the problem. The other thing is, if you do circumcision in neonates, it needs to be done by surgeon because it's a bit more difficult. I can do circumcision, but I can do only in children more than 5 years old. Less than 5 years old, I'm not confident. So usually in neonates, it's done by surgeon. But the sunnah is you do it by by 7 days, by day 7 of life. So that is the sunnah. So later on, if you guys have children later, try and follow the sunnah. So you do as early as possible. The other issue is if you look at suggestion from American Pediatric Association. So American Pediatric Association mentioned about the benefit of male circumcision. So male circumcision is proven in adult, it can reduce risk of sexually transmitted diseases, but in newborns, it may help in terms of reducing number of UTI, urinary tract infection. So in children, in newborn, it helps in terms of reducing the incidence of urinary tract infection. But it is useful only if it's done less than 6 months old. So circumcision less than 6 months old, there is benefit of reducing UTI. So that is why circumcise your child early. So follow the sunnah, don't follow Melayu. If you follow Melayu, you won't go anywhere. Okay, all right.
okay, thank you, Doctor, for that additional information. And okay, so if the patient is among toddler age, in hemophilia patient, usually they will present with multiple bruises since this is the period when they started to walk. Okay, for adolescent, they may come with complaint of menorrhagia. So this can be suspected due to von Willebrand disease. Okay. Other than the age, we need to know the associated trauma that predisposed to that symptom. So if there is trauma, we need to know to what extent the trauma actually occur. And if it's only a mild trauma, so the extreme bruises is very significant. And if the bruises also can occur spontaneously without trauma. Okay, and then we need to inquire regarding the location of the bruises, whether it's involve multiple area of the body or only localized at one site. And we need to know specifically at the site, whether it's the trunk, back, genital area, sole, or palm, which is very suspicious to have those kind of bruises at that site. Okay. Other than that, we need to know the pattern of the bruises. If there is a mucosal membrane involvement, it can suggest the bruises due to platelet disorder or von Willebrand disease. If it is bleeding into the muscle or joint, maybe secondary to hemophilia. Or if the bruises have a scarring and delay in terms of bleeding, can suspect for connective tissue disease, such as example given would be Marfan and osteogenesis imperfecta. Okay. Other than that, we need to know the onset of the bleeding, whether the bleeding immediately occur, like in platelet dysfunction, or there is delay in whether the bruises is immediately occur, for example in platelet dysfunction, or bruises is delay. example for coagulation factor disorder. Okay, for the next slide. Okay, further history, we need also to inquire regarding if the bleeding is prolonged even after a minor procedure, such as during dental procedure or after receive any vaccination. Okay, spontaneous bleeding without a cause, already mentioned before. So we do the systemic review. We ask whether the patient have any fever, URTI symptoms, since ITP can followed after a viral infection. Okay. Other than that, we need to ask regarding the yellowish skin, stigmata of chronic liver disease, or there is any history of recurrent infection, lethargy, rapid bleeding, or constitutional symptoms that could suggest for leukemia. And is there any joint hypermobility, skin elasticity, and poor wound healing? Okay, this one is for I don't remember. I will mention the disease later. I forgot the name. I'm sorry. Okay, and then ask regarding multiple fracture with suggestive of osteogenesis imperfecta. Okay, so for the family history, if there is any relative with the similar presentation as the patient, we need to know the gender of the relative affected. If the gender was boy, so hemophilia was strongly suspected. Okay, for the drug, we need to know in detail what type of drug that the patient currently on, whether it's antiplatelet, anticoagulant, NSAID, or steroid, which all can cause prolonged bleeding. And also we need to know regarding the diet history of this patient, since vitamin C deficiency can lead to scurvy, and scurvy can present with gum bleeding. And if the patient have vitamin K deficiency, it will disturb the coagulation factor synthesis. Okay. For patient that already reached the puberty, we need to know whether they having any symptoms of menorrhagia or metrorrhagia. And for social history, we need to exclude any risk that the child may be being abused. For example, if the parent is substance abuser or having any mental health, or being cared by non-biological caregiver, or living with single parents. Also, we need to know regarding the financial status of the parents. Okay. Next one. Okay, moving on to the physical examination. Okay, for general inspection, we obviously we expect to find any types of bleeding, whether it's a mucosa of soft tissue that could indicate that it is a mucocutaneous bleed. And usually, if the bleeding is mucocutaneous, it usually indicate that the problem is with the platelet or with the von Willebrand disease. If we saw that there is a muscle and joint swelling, it indicate a deep bleeding. So more towards severe kind of disorder. For example, hemophilia. Okay. We need to describe the appearance and distribution of the bruises. Whether is the common area will be at the distal part, anterior tibia, knee, and forehead. For the upper extremities, we need to know whether the patient has any assisted in ambulation, maybe bruises from the crutches being used, or what else? Okay, and then the third point would be location that usually secondary to the patient being abused, such as at the trunk, back, genital, or any specific shape of the bruising. Okay. Regarding the color of the bruises, it's very difficult for us to determine whether the bruises is a recent lesion or older lesion. But they said the recent lesion would be red, blue, or purple in color, while the older bruises will appear yellow, brown, or green. Okay. Other than the ecchymosis, we need to find other sign of petechiae, purpura, hematoma, hematrosis, or other site of bleeding. Okay. Later I will differentiate. I will talk about how to differentiate with this with the types of the manifestation. Okay. And then we need to rule out any signs of liver disease or any other signs of child abuse. Okay. Next one. Okay. Can you guys guess what is this picture? What condition of this picture? Is ecchymosis or hematoma, hematrosis?
Hematrosis.
Hematrosis.
Yes, that's correct. It is a hematrosis. Alright, I think it's already developed into atrophy. Okay, next one. Okay, this to differentiate the accidental bruising pattern with the abusive bruising pattern. Okay, all right, next one. Okay, so this one are strongly suspicious of being abused. As you can see, if the child have been gagged, you can see the bruises around the mouth, and you can see there is a blistering and edema surrounding the wrist, the wrist of the hand. And usually, if there is a specific pattern of bruises, such as you can see the hand, you can see the fingers, and you can see the way the device that is being used, the bruises follow the pattern. Okay, it's very important to inspect the genital part and the surrounding area. Okay, okay, next one. All right. Okay, okay, so from the this picture, the first picture are this show how the pettike, the appearance of pettike. So pettike is a non-blanching appearance with less than 2 millimeter in size, while purpura is a group of adjoining pettike. While ecchymosis is the second picture. It is an isolated lesion larger than pettike. The diameter given was more than 10 millimeter, and hematoma is described as wrist and palpable ecchymosis. Okay. So next, once we see the patient and we suspect it due to the blood disorder, maybe we want to do a screening investigation. So we would do a full blood count to see the platelet level, and can do blood film is if we suspect it to rule out leukemia, or maybe it's not only platelet problem. Okay, and then we can do coagulation profiles such as PT and APTT. And if PT or APTT is prolonged, we can do a mixing plasma investigation. If I'm not mistaken, they mix the plasma. They mix the plasma that we taken from the patient with the normal plasma that have a normal value of coagulation factor. So from that investigation, we distinguish whether the problem of prolonged PT or APTT is due to factor deficiency or due to the presence of inhibitor. Alright. And then the thrombin time to test for deficiency or dysfunction of fibrinogen. The quantitative fibrinogen assay just to rule out whether the bleeding, the problem secondary to hypofibrinogen or hyperfibrinogen. D-dimer can test for the FDP. Also can be used if one of our differential is the IVC. And we can also do biochemical screening to rule out other systemic causes. Okay, next. Okay, this one taken from the Nelson. It is more detailed, but just the same like I mentioned before. Okay, just moving on to the management. Okay, so the management, it according to the disease or that the patient have actually. So if in terms of supportive management, we can do a collect of blood transfusion if patient presented with hypovolemic or anemic, and we need to correct any coagulation.
Nadira, can you go back? Can you go back?
Okay, Aklan, can you go back the slide?
Okay. If you think this child has a platelet problem, problem with platelet, but the platelet count is normal, what else you need to think?
Platelet problem, but the platelet is normal.
Motor dysfunction, platelet dysfunction.
Yes, platelet function, because platelet is not just about the count, it's also platelet dysfunction. So this is something that you need to remember. Do you know one drug that affects this issue? One drug that affects platelet function?
Aspirin?
Aspirin, yes, very true. So sometimes if you there are certain diseases where you give high dose aspirin, for example. Most of the time you give a prolonged usage of aspirin. But if the dose is not given properly, so aspirin, different dose give different effects. High dose gives what effect? High dose anti-inflammatory, isn't it? Lower dose give platelet punya effect. So if you give high dose for a very long time, sometimes there can be risk of bleeding and whatnot. So you need to remember what are the drugs that may cause, not just aspirin, and NSAIDs as well, NSAIDs. NSAIDs can also affect platelet function. For example, things like ibuprofen, there's a problem with platelet function. So that is why, for example, you have a child, you have a newborn with patent ductus arteriosus. So among the way for you to close the PDA is to give ibuprofen because prostaglandin, isn't it? So ibuprofen and NSAIDs blocks the prostaglandin pathway. Then, so prostaglandin actually keeps the PDA open. So if you give ibuprofen, it inhibits prostaglandin and then the duct will close. But the problem is if the platelet count is not good, so the problem there may be bleeding, especially in newborn. Okay, that's one thing. Second, which one shows intrinsic or extrinsic pathway, PT or APTT?
APTT show intrinsic pathway. For PT is extrinsic.
So PT shows intrinsic, ada tulis kat situ kan. So look at PT and APTT. So if APTT is mainly the one that's prolonged, so you think about things like hemophilia and things. Okay, all right, next, proceed.
Okay, okay, regarding the management, all right. Okay, if there is a massive bleeding, but we didn't know exactly what the causes is, we need to first treat with blood, give fresh frozen plasma, plus minus platelet as indicated until the precise defect is known. And we need to avoid from intramuscular injection, acupuncture, and NSAID from giving to the patient. And we need to refer to hematologist and blood bank early when the patient is being presented. Okay, that's for the general management. Okay, next slide. Okay, take a deep breath. And okay, lastly, I'm going to talk about the common cases. All right. So for the common cases, I choose ITP and hemophilia because I met this patient during my previous pediatric posting during year 3. So ITP, the etiology for the childhood ITP is a very common disorder that follows usually follows after acute viral infection. So the childhood ITP occur after the antibody actually attack the platelet, bind to the platelet membrane that lead to the destruction of the platelet itself. Okay, but ITP could also be a presenting symptom for other autoimmune disease such as in SLE. So the clinical manifestation in ITP in young children, as I mentioned, can present 1 to 4 weeks after viral illness with history of abrupt onset of petechiae, purpura, and epistaxis. So usually the platelet level in this patient are very severe, and there is unusual presentation of an adenopathy or hepatosplenomegaly. Their RBC and white blood cell level are normal in ITP. Okay, so the treatment for ITP is that the most children remit spontaneously, means that we didn't need to admit all the patient that come during acute presentation unless there is a severe life-threatening bleeding and the platelet count less than 20 with bleeding manifestation, or the platelet count less than 20 without bleeding but inaccessible to healthcare, and patient and we have a lack of confidence in home care, so we admit the patient. Okay, so the choice of treatment available according to the
Nadira,
yeah.
why don't you want to transfuse if it's less than 20 but no bleeding? Why don't you want to transfuse?
Don't want to transfuse?
Kenapa tak nak transfuse? Why don't you want to transfuse?
Because even though we transfuse, the platelet will keep destruction because the antibody will still attach to the platelet?
Yes, the thing is the more you transfuse, because platelet even though it's not like RBC, it's not like RBC where apa nama dia ada banyak antigen kan. So basically platelet ni kita tak payah buat pun blood grouping dan sebagainya because antigen dia tak. Tapi still the more you transfuse, the more antibody form. The more you transfuse, the more antibody form. The more antibody form, the more problem will occur. So that is why we don't actually transfuse unless it is actually needed. Okay, that's the reason why. Okay, all right, continue.
Okay. So the choice of treatment based on the PITS protocol, they offer for oral prednisolone and IVIG. However, if the child doesn't give any significant benefit from the steroid usage, we need to stop the steroid. And then for the IVIG, we need to monitor for the side effect, especially fever, headache, and nausea. Okay. In terms of emergency treatment, we can consider platelet transfusion in very severe cases and also stem cell transfusion. However, if other modalities fail, we need to refer to surgeon for emergency splenectomy. But keep in mind, the treatment is directed at the clinical status of the patient and not the platelet count. So if the patient appear well, and not toxic looking or everything, we just monitor the patient. Okay. Alright.
Another
Yeah.
drug that you can use other than prednisolone and immunoglobulin.
Metaprednisolone in severe case.
Metaprednisolone is steroid lah. So basically other than steroid and immunoglobulin, what else? Another drug.
Another drugs. I'm not sure.
TD ke?
Anyone else?
TD.
Is it methotrexate?
No, NTD is true. So Rogam, NTD is another good drug that you can use. But usually it's not the first line lah. You try with prednisolone, immunoglobulin first, and then if it doesn't work, then you can consider giving NTD, which is Rogam. So Rogam is useful as well. I've seen few patients that need Rogam, and they respond quite well. Okay, proceed.
Alright. For the next slide. Okay. For the hemophilia, hemophilia actually the X-linked recessive genetic disorder. So it's divided into A and B. So for A is deficiency in factor 8. B is deficiency in factor 9. So as you can see, the percentage of hemophilia A is more than hemophilia B. Okay. In terms of clinical manifestation, the severity of the hemophilia can be divided according to the level of the factor. So if the level of factor is less than 1%, we consider it as a severe type of hemophilia, which will have spontaneous bleeding or high risk intracranial hemorrhage. Okay, but if the factors level is 1 to 5%, it is a moderate type of hemophilia, while mild type of hemophilia is 5 to 25%. Okay, moderate and mild type hemophilia will only bleed with trauma, surgery or dental procedure. They will not have a spontaneous type of bleeding. Okay, so as I mentioned before, easy bruising occur during 9 to 12 month old because this time they start to crawl and walk. And usually the common presentation would be hemaarthrosis that involve large joint, commonly knee, ankle, and elbow. It also swollen and also painful. Okay. Patient also can have complaint of epistaxis, gum bleeding, and hematuria. Okay, regarding the diagnostic investigation for hemophilia, we could do full blood count to see the platelet level. However, it's supposed to be normal since the problem in coagulation factor, not the platelet. Okay, and then we start to screen for the coagulation, which will do PT and APTT. Okay, at this point, we expect PT to be normal. Okay, and if hemophilia is the disease, the APTT should be prolonged. Okay, all right. And then, but if the APTT is normal, we need to screen for von Willebrand disease. All right. Okay. So when the FPTT is prolonged, we proceed to the coagulation specific factor assay, which we measure the level of factor 8 and factor 9, and we see which one is the one that reduced. All right. Regarding the treatment, okay, PITS protocol said that we can give prophylaxis. However, it's very costly, and the administration of prophylaxis require a central venous access. So I'm not sure whether we practice to give prophylaxis in hemophilia patient. So the prophylaxis, the aim is to prevent atropathy and to ensure a good quality of life. So the treatment of prophylaxis is just we give factor 8 and factor 9. Okay. And then if the patient was presented with
Nadira, prophylaxis we can give prophylaxis factor. And you said giving factor central line.
it was said that we need administer by central venous access.
No lah, actually you can give factor, you can give by normal peripheral cannula je pun. Cuma the only problem is sometimes if you frequently need to puncture the patient for cannulation, so by few years, and then it will be very difficult to put lines in. So sometimes in this sort of patients, sometimes you may consider putting a central line, putting something like a chemo pod or something. So yang tu you can easily take blood, you can easily transfuse factor. But in many centers in Malaysia, we don't even put chemo pod or anything, a central line, Hickman, apa kita tak buat. Because it can be given by peripheral access. But ideally, the problem with peripheral venous access is you need to puncture so many times, and when the factor level is already low, each time you puncture, you will cause bruising, extensive bruising banyak, and then will destroy the line. So lama-lama after few years, it's difficult lah nak set line pun. It will be difficult to look for vein, kan? So that is why in certain patient macam ni, dia suggest kita pasang central line, such as Hickman line kat leher ataupun chemo pod.
Okay. Alright, Doctor, actually I want to ask regarding the prophylaxis and replacement therapy, what is the difference between these two actually? Means that
replacement is when you know it's low and then you give it to basically to replace lah. But prophylaxis ni in certain patient yang severe ni, sometimes you give regularly prophylaxis factor just to improve the quality of life apa semua lah. So basically you just give in regular intervals.
Okay. Alright. Okay, then regarding the prophylaxis and regarding the replacement therapy, as mentioned, when patient was presented to hospital with complaint, and we in hemophilia patient, we cannot give fresh frozen plasma and cryoprecipitate because it could have a high risk of viral transmission. And other type of treatment that we could offer is a supportive treatment, which will give analgesic if patient complains of a painful joint, or we educate encourage patient to have a good dental care to avoid going to the dental procedure, and vaccination since to avoid patient from having recurrent infection.
Okay, let me say something. So right. FFP character should not use because of high risk of viral transmission. Okay, it's the same lah maknanya. If you transfuse blood for everyone, if you transfuse blood, siapa-siapa yang accept transfusion of FFP, cryoprecipitate or paxil transfusion or whole blood, semua ada risk of viral transmission lah. Kan maknanya HIV, hepatitis B, hepatitis C, macam-macam virus apa semua. So these are risk of viral transmission. The issue with hemophilia is they need frequent blood transfusion. They need frequent blood because factor is blood. Factor ni diambil daripada orang yang donate blood kan. So they need frequent transfusion. So bila need frequent transfusion, kalau you selalu bagi cryoprecipitate, bagi FFP, the risk of viral transmission is higher lah, kan? And then if you give FFP cryo semua, you are giving the whole factor punya group. You are giving everything. Sedangkan yang patient tak ada is just factor 8 or factor 9. Kan? So that's why you don't actually give everything. So you give certain. And then some more, kalau you jenis bagi macam-macam, there'll be inhibitor. Bila ada inhibitor, it be difficult. So sebab tu kita kena bagi, ideally you give the factor replacement, not you bang dengan FFP and cryo, because the more you get FFP, the more you give cryo, the more inhibitor will form. Okay.
Alright, I think that's all for my presentation. I think that's the end of my presentation.
Okay, one more thing I need to remind you all, in regards to a child with bleeding, with bleeding, bruising kan. You need to remember as well, neonates dia ada banyak lagi neonates dia ada isu macam hemorrhagic disease of newborn, dia ada isu NAIT, NAIT. So NAIT is, siapa tahu NAIT tu apa? Newborn autoimmune thrombocytopenia. So basically the platelet is low, but it is autoimmune. So you need to remember. So in newborn dia ada banyak lagi benda yang you need to look at it. Okay. Benda macam ni kena tahulah. Okay. Sekarang dah pukul 4:20 dah. Let's go to the next presentation.
Assalamualaikum.
Sorry, I have questions about I'm not sure if I missed this before, but I'm not sure about the treatment of hemophilia, about the prophylaxis. How long can we give prophylaxis, and if the babies or the children suddenly get hematrosis, even he had under prophylaxis, is the management would change into replacement, or how it will go?
Prophylaxis is if you plan, you give prophylaxis regularly. Replacement is when there is something. So sometimes when there is bleeding, when there is hematrosis, dia ada calculation dia. If hematrosis you think is how many percent? If the child is going for if bleeding in the brain, is how many percent? So you need to, replacement is basically that two ways. So first, sometimes macam mana? You can either assume. So kalau ada bleeding in the brain, you need to replace 100%. Kalau there is bleeding in the joint, you need to replace 60%, for example, macam tu. Ataupun you check factor level and then you replace accordingly. So, bila you check factor level, dia akan bagi tahu berapa persen yang ada. So you can replace accordingly. This is replacement. So this is just acute punya management. So maknanya bila ada event, you replace. Prophylaxis ni pun ada several. Satu, you give regular. So contohnya every 4 weeks you do factor replacement. Patient admit ward, you bagi factor transfusion every 4 weeks, for example. Ada juga yang you bagi prophylaxis prior to procedures. Sebelum buat dental procedure, you bagi. Sebelum buat surgery, you bagi. Sebelum buat something, you bagi. So this is prophylaxis. So yang tu pun sama juga, dia ada calculation dia lah. Buat surgery, how many percentage you need to replace. So this is prophylaxis. So prophylaxis is basically to prevent more complication, hematrosis, macam-macam benda, to prevent that. Tapi kalau jadi you bagi replace masa tu, tapi you can still continue prophylaxis. Cumanya you kena consider lah. Satu, you kena consider adakah you kena naikkan dose of replacement. So you do not replace dose prophylaxis yang you bagi tu. So dia ada calculation dia. So probably you need to give a bit more. So you need to calculate. So adakah the dose is not enough? Satu. Nombor dua, is it because of inhibitor? So because if it's inhibitor, sometimes you nak kena bagi yang specific punya, ataupun you nak kena change dia punya factor yang you bagi. Ataupun sometimes kalau ada banyak inhibitor, sometimes you kena bagi steroid dan sebagainya. So it's a bit more difficult lah.
So Doctor, it means prophylaxis is lifelong lah.
Yes. Hemofilia ni selalu masuk exam juga tau. Especially kalau dia tak masuk soalan pasal hemofilia itself, dia boleh datang in terms of OSCE, cuma sangat hemofilia keluar, kita bagi hemofilia ni ada dalam one royal family. Which royal family ada hemofilia?
British.
Richard.
Queen Elizabeth.
British royal family ada hemofilia. So this is very well known kan. Dan dia ada genetic punya komponen. So kita boleh bagi family tree. Kita bagi. So what's the diagnosis for example? Benda macam ni lah. So hemophilia is another disease that you need to know. Okay, next.
Assalamualaikum warahmatullahi wabarakatuh. So inshallah, my name is Muhammad Aflan. So I will continue the presentations with the next slide. So can you all see my slide? Okay, if there is any interruptions, you can just tell me within the by using the microphone. Okay. So Assalamualaikum warahmatullahi wabarakatuh and very good morning to all. So this is my topic today. So we're going to go into the approach to child with jaundice. So previously during last week we've covered about neonatal jaundice. So today we're going to touch about jaundice in child. So there are some differences in as to why we're going to cover this topic. Okay, so this is my outline for my presentations today. So we're going to go into the introductions, and then we're going to go into a bit about the biochemistry with regards to bilirubin metabolism, and then we're going to look into the classifications of jaundice and the causes based on this classification. And then we're going to look into the approach to a jaundice child, and then we're going to see the references. So for my presentations, the main reference will be from Nelson Essential, Nelson textbook, Ashcraft textbook, and also from Harrison. Okay. So jaundice, what is it? So as you can see, that's pictures of Homer Simpson. So as you know, the cartoon Simpsons, they are very yellow. So jaundice is actually defined as the yellowish discoloration of the sclera, skin, and also the mucous membrane. So this is attributed to the pigment that is given off by the bilirubin, which we cover later on. So it will manifest when we will have a state of hyperbilirubinemia. So we have a different cutoff value as in neonates and also as in children and also older adults. So in neonates, if we are to refer into the pediatric protocol, the cutoff value is actually more than 85 micromoles per liters of bilirubin to manifest clinical jaundice. Whereas in children and older adults, if you refer to Nelson textbook, it is ranged at 34 to 51 micromoles per liters. So the same value is actually being quoted in Harrison textbook. So bilirubin.
This value is in general lah. It doesn't. This is just at which level that you can actually appreciate jaundice. So it depends on several things. It depends on the environment. Kalau patient tu pakai baju warna yellow, the child, even though the bilirubin is low, you will see the child is jaundice. Kalau dia punya bilik tu is color is yellow, kan, langsir pun color yellow, so you will see the child is a bit more jaundice even though the bilirubin level is low, kan. So it depends juga. Kalau you seumur hidup tak pernah tengok, you've never seen any jaundice patient, obviously you need a higher level of bilirubin for you to appreciate jaundice. But if you've seen jaundice every day, then even much lower than this also you can appreciate jaundice. So this number is arbitrary lah.
Thank you, Doctor, for the input. So we'll continue on. So bilirubins have two states, the conjugated and also the unconjugated. So as we learned before that the conjugations will occur at the livers, and this I will touch later on. So jaundice can also be divided, aside from the states of bilirubins, it can also be divided into the anatomical sites, pre-hepatic, hepatic, and post-hepatic, with each classifications have different etiologies. Okay. So jaundice, now we're going to talk about the biochemistry behind jaundice. So first and foremost, we have the red blood cells, erythrocytes. So the lifespan is about 3 months. So I think this is touched a bit by Dahia previously. So when we have a erythrocyte that has been broken down, either intravascularly or extravascularly, they will be break into heme and also globin. So this globin will then be broken into the constituents amino acid, and then we'll recycle later on, while the heme will be undergo oxidations by heme oxygenase, and then will be converted to becomes biliverdin. then biliverdins will become bilirubins by means of enzymes biliverdins reductase. So this bilirubin is in the states of unconjugation, and it will require binding to albumin for it to transfer within the blood circulations, because unconjugated bilirubin is lipophilic and it is hydrophobic. So the binding to albumin will make it less hydrophobic and allow the solubility to be disseminated in the system circulation. And this unconjugated bilirubin, as we learned before, that this is the main culprit behind kernicterus, because it can pass readily through the blood-brain barriers because of its lipophilicity nature. Now, having said that, after the bilirubin has bind to albumin, it will be then transferred to liver for the process of conjugation. So this is the enzymatic pathways I've taken from Harper's Clinical Biochemistry textbook. So the bilirubin will then be undergo conjugations by the enzymes UDP glucuronyl transferase. So it will convert it to become the bilirubin's monoglucuronide, and then with second conjugation will occur, convert to become the bilirubin's diglucuronide. So this is the state of the conjugated bilirubins as we speak. So, and then later on, it will then be mixed with bile and then be excreted into the biliary tree and then into the duodenum. And then from the duodenum, there will be intestinal bacterial enzymes, the glucuronidase enzyme. So this will convert conjugated bilirubins to become urobilinogen. And then within the terminal ileum, there will be some enterohepatic circulations that will absorb back the urobilinogens to be recycled. And then those that are left within the intestinal tract will be converted to become stercobilin, which gives rise to our dark colored stool. And then from those that enters back into the circulation, some of it will be recycled, while some of it will go to the kidney and later on be converted to become urobilin, giving rise to our amber-colored urine. So this is the basic biochemistry. Well, it is important because of its clinical correlations later on. Now, having said that, we're going to move into the classifications of jaundice. So we can divide jaundice into unconjugated hyperbilirubinemias and also conjugated hyperbilirubinemias. So the unconjugated one will occur at the prehepatic and also hepatic level, whereas the conjugated will occur post-hepatic. Having said that, so if you look into this, is the table taken from Nelson Essential. It's a very exhaustive list, but we can generally divide it into this classification in order to ease us in memorizations later on. So if you look for unconjugated hyperbilirubinemias, we have the hemolytic causes and the non-hemolytic causes. So hemolytic causes, we have, like we discussed multiple times, we have the hemolytic anemias, we have the rhesus isoimmunizations, incompatibilities, and then we also have the G6PD deficiency in hemolytic crisis. We have hemoglobinopathy such as sickle cell anemia, thalassemia, and also red blood cells membrane defects such as hereditary spherocytosis. So we look into the no hemolysis, the non-hemolytic causes. So we have the Gilbert syndrome, Crigler-Najjar syndromes. I will touch with this later on. And then we have the physiological jaundice of the newborn. So this is occur because of the immaturities of the livers. It lacked the adequate UDP glucuronyl transferase enzyme to allow adequate conjugation. So that's why we have the physiological jaundice. Another one, if we refer to Dr. Taufik lectures during our year 2, actually it is also attributed to the fact that we have the hypomotility of the gut, and this will cause more circulations of bilirubins reabsorbed into our circulations, causing the jaundice. And then we have the breast milk jaundice. So in Nelson textbook of pediatric mentioned that this is because it will inhibit the uptake of bilirubins into the hepatocyte for the conjugation later on. And then hypothyroidism, because of few things. First and foremost, the state of hypothyroid will cause the decrease in the conjugation process enzyme. And another one is because of in hypothyroidism, we know that there will be a constipation. So this constipations, hypomotility of gut will cause the fecal material will be retained more longer within the GIT. So more circulations, reabsorption for circulations will occur into the enterohepatic circulation. Pyloric stenosis. So if you open Ashcroft textbook, it mentioned that it's actually because in pyloric stenosis, we have the associations with decrease in enzymatic activity, but it is not further elucidated in the textbook. And then also we have the internal hemorrhage. And then for the conjugated hyperbilirubinemias, focus on the obstructive, we have the Alagille syndrome. So I will cover this later on. And then biliary atresia, and then we have all the other lists. So having said that, we can also classify based on anatomy. So we can divide into pre-hepatic. So as I mentioned before, they basically more or less the same same causes, but this is defined according to the anatomy. And then we have the hepatic causes. So as mentioned before, either decrease uptake of bilirubins or decrease in the conjugations process within the liver in itself. So I will talk a bit about Crigler-Najjar syndromes and also Gilbert syndrome. Okay. And so this is the post-hepatic. So focus on the usual classifications. We have the intrahepatic and also the extrahepatic cholestasis. This one, intrahepatic, extrahepatic, and also the other causes. Okay. Now we're going to look into Crigler-Najjar syndrome. So as I mentioned before, the defect, this is one of the causes of hepatic jaundice, where there will be a decrease in terms of the conjugation. So there are two types, type 1 and type 2. Both are autosomal recessive in actuality. So actually type 1 is the complete absence of UDP glucuronyl transferase, meaning that there is no enzyme to conjugate the bilirubin to become conjugated bilirubin. So patient will present with unconjugated hyperbilirubinemia. And having said that, this is because of this, this one is I mistakenly put here. Supposedly it will be unconjugated bilirubin, so we won't see the obstructive symptoms. I will edit this later on. So risk of kernicterus will persist until adulthood because we don't have the enzymes to conjugate. So the bilirubin will remain continuously within a state of unconjugation, and this unconjugated bilirubin mentioned before has a lipophilic nature, cross the BBB later with much ease. Diagnosis will depend on liver biopsy and also DNA analysis, checking for the gene. And also the treatments, phototherapy, and also liver transplantation. The liver transplantation will be the definitive therapy, whereas the phototherapy mentioned in Nelson textbook that we need to continue until adulthood because of the risk for kernicterus to develop. However, as compared to neonatal phototherapy, this one we only apply at night because we want to allow the children to roam freely during the daytime to resume their activities. Basically, phototherapy, the mechanism is actually the same as compared to the neonatal one.
What does phototherapy do?
So phototherapy, I've in the textbook doesn't mention, but in the one of the article that I've read is that it will convert the unconjugated bilirubin into two isomer. We have the structural isomer and also the configurational isomer. So these two isomer are more water soluble, hence allowing the excretions of bilirubins to occur from our blood circulation.
So the term is photoisomerization. So the light causes the unconjugated lipophilic bilirubin to photoisomerize and change into a more water-soluble form. So, but you need to make sure that the child passes urine. So especially in newborn, sometimes they are oliguric for the first few days. So if they are oliguric, so how can you reduce the bilirubin level? And also you need to make sure that the child passes opens bowel. So because if the child doesn't open bowel, how can the bilirubin go out? Then it will be recirculation as well. So photoisomerization.
Thank you, Doctor. And then continue on, we have the type 2, about the same autosomal recessive, but this in case of type 2, it is partial absence of the enzyme. So actually there's a test to differentiate between type 1 and type 2. We call it as the phenobarbital challenge test, but I'm not sure if this is done clinically or not. Basically, the phenobarbital is an enzyme inducer. So what it will do is that we give the phenobarbital. So this phenobarbital will then induce the activity of the enzyme. So those with type 1, because there's no enzyme to begin with, so we don't expect any decrease in the unconjugated bilirubin level. Whereas in type 2, there will be improvement of about more than 25% after the challenge. But perhaps doctor can share if this test is done clinically, doctor? Phenobarbital challenge test.
I've not seen, but phenobarbital is actually used for things like conjugated hyperbilirubinemia. So sometimes we do give phenobarbital because it does help. But this test, I'm not sure. Crigler-Najjar is very rare. I've never seen Crigler-Najjar.
Okay, thank you, doctor. And then presented same unconjugated hyperbilirubinemias, variable jaundice, no pale stool. And then risk for coronavirus unusual as compared to the type 1 because we have still the enzymes functioning. And then treatment in textbook mentions the phenobarbital. We give as 5 mg per kg for once daily dosage. Okay. And then we move on. These are some differentiation in summary. So I think we don't need to cover this more. Gilbert syndrome is actually similar pathologies involving the UDP glucuronosyl transferase enzymes activity, but it is a milder form as compared to Crigler-Najjar. If you can see the comparison, it is much more milder in terms of all the parameters that is being compared as compared to the Crigler-Najjar type 1 and type 2. But basically, it's the same thing. The pathology involved the UDP glucuronosyl transferase enzyme. I tried to search for the prevalence in Malaysia, but I've only found there's a one paper. Actually, one of the author is Prof. Leila from IIUM. But there's no mentioning of any specific prevalence. There's mentioned that which type of mutation is common in Gilbert syndrome. There's a subdivision. Actually, I will not touch that. We can refer to textbook. Okay. Now I'm going to talk into some of the causes for obstructive jaundice. So we have the biliary atresia. So this taken from Ashraf textbook. So it is obstructive jaundice presented with conjugated hyperbilirubinemias. It is described as the absence of the entirety of the part of the biliary tree. So we have 4 subtypes. So 5% are correctable lesions where we have the patent cystic duct and CBD. I will show the picture later on. And then the 90%, the rest of it will be non-correctable. So this is the pictures taken from Ashraf. For type 1, we have the CBD will obliterate. So we don't have any CBD. Type 2 can be divided into 2A and 2B. 2A, we have the common hepatic duct pathology. So there's no common hepatic duct. And then 2B, there's a combination between the CBD and also the common hepatic duct obliteration. Whereas 3 will be total, but the entire biliary tree will be obliterated. So diagnosis, gold standard, if we refer to Ashraf, will be liver biopsy or direct visualization by open or laparoscopic. But if you refer to PITS protocol, we use ultrasound and also GGT, gamma glutathione transferase. So in ultrasounds of the hepatobiliary system, because the commonest cause of biliary atresia is actually the third one, actually. So we have the total obliteration of the biliary tree. So what we'll see is that there will be absence of contracted gallbladder because there's no bile flow to the gallbladder. So during ultrasound, we won't see the gallbladder there. And also we have the dilated intrahepatic duct, obviously, because the bile is obstructed. There's no outflow, so it will congest the intrahepatic biliary tree, bile duct, sorry. And then in pediatric protocol, if you refer, if we have the clinical obstructive jaundice, the characteristic pale stool with the dark urine and also presence of pruritus, jaundice also. And then in concurrence with that, we also have the elevated GGT is highly suggestive for biliary tree obstruction. So in such cases, the protocol mentioned that we need to thoroughly try to rule out biliary atresia. Other investigation, of course, liver function test and coagulation profile because it can affect the coagulation pathway, in particular the 27911, which is the vitamin K dependent, which is the fat soluble vitamin K. Okay, management Kasai procedure and supportive vitamin K supplement. So Kasai procedure is actually this one, hepatoportoenterostomy. So this is covered actually in pediatric surgery more. So basically we create the anastomose. So we directly communicate the duodenum with the ileum with the porta hepatis, and also the distal part of the duodenum will do the end to side anastomosis with the ileum. Now we go to Dubin-Johnson syndrome. So Dubin-Johnson syndrome is not common; it's very rare, and it's more common in Caucasian actually as compared to Asian. And then Dubin-Johnson syndrome is actually one of the post-hepatic causes, autosomal recessive mutation at the ABCCA gene. Actually, MRP2 protein is one of the protein used to transport the bilirubin that has been conjugated into the bile duct. So imagine we don't have that protein, so the conjugated bilirubin will remain within our liver, cannot be excreted out. Okay, same thing, conjugated hyperbilirubinemias, bilirubinemias. So actually, it's more often is asymptomatic. Exacerbations will occur at pregnancy or OCP when there is intercurrent illness, or in other words, the the conditions that can cause impairments of the conjugation activity, such as pregnancy or OCP, is the one that can cause jaundice, but usually it is asymptomatic. And then we have the bromsulfalin test. Actually, this one in the textbook mentioned that we inject it intravenously. So imagine that we have the conjugation occur. This is actually a cholecystic agent that gives rise to contrast. So imagine that, it is absorbed into the liver for conjugation. So imagine that we have the conjugation of this enzyme, of this substrate, the bromsulfalin, but there's no MRP2 protein to excrete it out into the biliary tree, so it will regurgitate back into a circulation. So we will expect a rise within the serum level of this bromsulfalin. Okay. Now allergial syndrome.
Back. Can you go back to biliary atresia?
Sorry. Yeah.
Biliary atresia. Okay, I just want to say just want to say something. Firstly, is for biliary atresia, biliary atresia is the most important differential diagnosis to rule out if you have a child with prolonged jaundice. So if you have a child with prolonged jaundice more than 14 days of life, so you need to rule out biliary atresia. So this is the most important. So in Malaysia, usually what do we first do if we have a child with prolonged jaundice? Apa first kita buat? Kita buat certain test kan. Kita hantar liver function test, thyroid function, because hypothyroidism can cause prolonged jaundice. Okay, bila you suspect budak ni ada conjugated hypobilirubinemia, what is the first test that you can do? So the first test is usually ultrasound lah. Ultrasound of the hepatobiliary. What can you see? You can see absent or contracted gallbladder. Okay, the next one in Malaysia. Okay, gamma GT is just part of the LFT. You can see already. So, but usually, what else can you do before you do liver biopsy? So you can do a test that is called HIDA scan. HIDA scan is a nuclear imaging lah, nuclear scintillography. So basically, you do HIDA scan. So usually after HIDA scan, then only we decide whether we proceed with liver biopsy or not. Usually they buat liver biopsy and then proceed with kasai. Sebab kasai, if you do kasai you need to do early. The earlier you do kasai, the more successful it will be. The later you perform kasai, most likely it won't actually be effective. And the standard, the proper treatment for biliary atresia is actually liver transplantation lah. So, but this biliary atresia you need to know, because even if you don't practice in pediatrics, you need to know about this. If you go to if you become a GP or you become MO in this in district KK mana-mana, you need to know prolonged jaundice. One thing that you need to rule out is actually biliary atresia. This is the most important diagnosis to rule out. Okay, all right, next.
Thank you, Doctor. So we're going into Alagille syndrome. So Alagille syndrome is actually there's a syndromic, one of the syndromes with the microdeletions of chromosome 20 P12. So there are certain it is actually one of the causes of conjugated hyperbilirubinemia, because there will be bile duct paucity. So meaning that the bile duct will not be in a continuous stream. There will be some paucity in between. So there will be biliary outflow obstruction. So Alagille syndromes, I will show the picture later on. They have certain pathognomonic facial features. They will have broad forehead. The eyes will be hypertelorism, increase in distance in between the pupil, and also there will be deep set of eye. And then the nose will be long and prominent, and then the mandibles will be underdeveloped. As for the eye, we have the posterior ambryotoxons, shallow anterior chambers, and microcornea. And also for the cardiovascular systems, we have the pulmonary stenosis, actually the commonest one. Patients can also present with pulmonary atresia and also tetralogy of Fallot, BSD, ASD, and also palpitation of aorta. And also musculoskeletals. Prof. Ismail mentioned before about the butterfly vertebra, which is one of the pathognomonic features. And then we have the spina bifida, and also fused vertebra can also occur. As mentioned before, bile duct paucity will be the manifestation in terms of the hepatobiliary system. So this is the pictures of one of a patient, one of the case report from one of article if you go search. So we can see that there is a deep set of eye and increase in the interpupillary distance, hypertelorism. We can see the prominent long nose, and then we can see the broad forehead. So as you can see here, it's very beautiful. It's like a butterfly, hence the name butterfly shape vertebra. So these are the pictures, these are the classifications for Alagille syndrome.
Alagille syndrome is very rare in Malaysia. The whole country, I think we only have 5, less than 5 patients, the whole country. And we have one in UAE.
Okay, thank you, Doctor. Okay. So now we talk about a complication of jaundice, which is kernicterus. So also known as bilirubin encephalopathies, as I mentioned before, because of lipophilicity cross the BBB. So it will deposit within the basal ganglia and also the brainstem nuclei. These are the two sites that when we do the biopsy postmortem, we can see the staining, yellowish staining of these structures. Occurs refer to Nelson mentioned that the levels will be 340 micromoles per liters or more than 20 mg per deciliter of unconjugated bilirubin. Risk factor, so if you refer to protocol, we have the sepsis, asphyxia, GCPD, and also isoimmune hemolytic disease. But if you refer to Nelson textbook, additional factors are put in, such as acidosis, temperature instabilities, extreme lethargy, and also the albumin level, because albumin is the one that will bind to the unconjugated bilirubin for transport later on. So looking at kernicterus, there are a few factors that we need to take into consideration. Albumin level will affect the risk for kernicterus, BBB permeability. So it is said that
Kernicterus is a postmortem diagnosis. So I don't actually like to use the term kernicterus. Bilirubin encephalopathy is much better lah.
All right, thank you, Doctor. So bilirubin encephalopathy, there are a few factors if you look into Nelson. The second factor will be the BBB permeability. So if you refer to Ganong, textbook of physiology, mentioned that it is rare in adult or in older children to get bilirubin encephalopathy as compared to neonates. Why? Because it is implicated that the blood-brain barriers is not yet mature in neonates. Hence why it is more leaky for the unconjugated bilirubin to later enters into the BBB, pass through the BBB. And then we have the unconjugated bilirubin level and also the neuronal susceptibilities to damage. So kernicterus in older children and adults, not as common as mentioned before, mainly because of two reasons. Because in adults and older children, the liver is more mature for conjugation process, and the fact that the BBB in adults and also in older children is more more mature and less leaky as compared to the neonates. Threshold in Harrison textbook actually mentioned that it is more than 35 mg per deciliter in order for us to develop the bilirubin encephalopathy. Okay, so role of phototherapy in older children, as I mentioned before, one of the indication is for Crigler-Najjar type 1. So phototherapy, actually in Nelson mentioned that the efficacy of phototherapy will reduce as the age increase. And then mentioned before that because of the bilirubin encephalopathy is not as common in the older and also in the adult populations. So we don't see much of a phototherapy role in those older age. Okay. Now, a systemic approach to jaundice, of course, history, physical examinations.
Wait, even in newborn, after 14 days of life, even if the jaundice is high, we don't actually give phototherapy. So phototherapy is only less than 14 days in term and only less than 21 days for preterm. Why? Because we know we believe that after 14 days in term, after 21 days in preterm, their blood-brain barrier is much more mature. So this unconjugated bilirubin doesn't cross that much into the brain. Risk of bilirubin-induced encephalopathy reduce. Bilirubin-induced neurological damage. So bind or bilirubin encephalopathy is reduced after 14 or 21 days. So that's why you don't actually give phototherapy. And then you remember in newborn babies, their skin and everything. This is why bilirubin is more effective. When you grow, the area, your skin thickness and things, so exposure of the blood vessels, the blood to the phototherapy is reduced. So that's why it's less effective.
Doctor, I have a question as to manifestation of bilirubin encephalopathy. Is it the same in older children as compared to neonates with regards to the presentation, Doctor?
Almost similar.
Okay, thank you, Doctor. All right. Again, for history, PE, and also investigation, we need to sell our provisional, rule out differential, and rule out the complication. I'm not going to go into details, but basically, the main gist is we need to check for the symptoms of obstructive jaundice first. Differentiate from non-obstructive jaundice. So obstructive jaundice, pale colored stool, dark because of the lack of stercobilin giving the pigment to our stool. And then we have the dark urine because of the regurgitations of conjugated bilirubin into our kidney, and then being excreted out with the dark urine. And then we have the pruritus because of the bile salt depositions. It's mainly attributed to the bile salt instead of the bilirubin. And then we have the jaundice. So these are the symptoms that indicate that this is actually obstructive jaundice. And then we have the non-obstructive jaundice. And then we go systematically in terms of the history, PE, to differentiate based on the causes. Okay. Investigations, I will touch a bit in depth, not really in depth, but more details as compared to history and PE. So in investigation serum bilirubin, so we need to determine the type of hyperbilirubinemia as in addition to our clinical judgments as mentioned previously. So in protocol mentioned that for the conjugated hyperbilirubinemia is defined when there is more than 50% of total bilirubin that is a direct bilirubin. And if this criteria is not met, it's considered to be unconjugated hyperbilirubinemia. Okay. And of course, workup for unconjugated bilirubins, because I mentioned before, we have the hemolytic causes and the non-hemolytic causes. So we can do check for the reticulocyte count, and then we can proceed further with direct cum test, full blood pictures, HbA electrophoresis, fluorescence test, and enzymes assay for disease PD. Osmotic fragility test for the hereditary spherocytosis, where we will dilute serial dilutions of RBC, so we can see that the RBC, because of its round in nature, it will eventually hemolyze because of the osmotic fragility. And then for the reticulocyte normal, we can do thyroid function test. As mentioned before, hypothyroidism is one of the causes, non-hemolytic, for unconjugated hyperbilirubinemia. If negative, we can proceed further with other investigations. We rule out the Kriegel-Najjar, rule out the Gilbert's, rule out the pyloric stenosis. Pyloric stenosis, actually, the investigation is ultrasounds of the stomach. So we can see there will be, the criteria is actually thickness of the pylorus is 4 millimeters or more, and then the length of the pylorus is actually 16 millimeters or more. That is the criteria in Ashcroft. Okay, obstructive jaundice, conjugated hyperbilirubinemia. These are the tests. I take this table from Nelson textbook. Yes, I think we can see the respective pathology with regards to respective tests. These are the summary of what we can expect to see biochemically, taken from Harper's textbook of biochemistry. So we can see the hepatic, prehepatic, and obstructive jaundice. We can see respectively the values to differentiate between these two. This is actually a summary of what I've just mentioned in length just now. Okay. Management, of course, will depend on respective etiology. Pyloric stenosis, we need to resuscitate and then give the pyloromectomy. We need to remove the pylorus, and so on, with respective pathologies, Kansai procedure for biliary atresia, and so on. These are my list of references. So, okay, so I think that's all from my part. So I open the floor for any questions.
Any question from the floor?
I would like to ask. I'm sorry if I can't hear you. If you have mentioned it before, regarding the Kriegler-Najjar and also Gilbert syndrome. Is there any test that we can differentiate them?
Okay, very good question. So I'm not sure if this is clinically done or not, but if you refer to Harrison textbook, it mentions of the use of the phenobarbital challenge test. Is one of the tests to differentiate between these two, because if we look into type 1 absent, so we induce banyak mana pun with phenobarbital, so you don't see a decrease in terms of the unconjugated bilirubin. And then if type 2, there will be about 25% decrease. And then kalau if you look into Harrison, the table just now mentioned that in Gilbert, because it's the mildest among the three, bilirubin will be normal after we induce with phenobarbital test. Other than that, I'm not sure what other tests. I think perhaps doctor can add more.
Genetic test.
Genetic. So I hope that answers your questions, Fitria.
Thank you.
Any other questions?
Assalamualaikum. My name is Muhammad Jazli. I would like to ask in regards to biliary atresia, why is the liver biopsy is done for investigation? Because like for the ultrasound, we understand because we want to see the patency, but for liver biopsy, how does it relate to us knowing that patient have biliary atresia?
Okay, good question by Jasmine. Actually, there are changes, specific changes, if we can see that there's changes from biopsy of the liver, but I think, I think why we need to do it, if we can demonstrate from ultrasound, I think a doctor can, perhaps doctor can add from this point.
So when I look at intrahepatic changes, because biliary atresia, it is not just the common bile duct, it's not just about the CBD. Sometimes the changes is intrahepatic. So the atresia is intrahepatic. So for prognostication and things, you need to look at the condition in intrahepatic. So then you know how to do the CASA procedure and things.
Thank you, doctor. Thank you.
If there is no question, okay, ada lagi. Sorry?
I know how urinary tract infection cause jaundice.
Sorry?
How urinary tract infection cause jaundice.
Okay, very good question. Okay, so how does, sorry. Okay. All right. So how does urinary tract infections causes jaundice? Ada cari tapi tak ingat. Kejap. I'm not sure. I'm so sure I don't remember. Okay. Perhaps anyone want to add?
So it's among the causes for prolonged jaundice lah, especially urinary tract infection. Few things. First is your conjugated bilirubin is excreted to your urine, isn't it? Through your urine. So sometimes urinary tract infection, they may be reduced urine output, and so on and so forth. The other thing is sepsis itself. Sepsis itself causes few changes. Sepsis itself can cause jaundice because it alters on the metabolism of the bilirubin. It alters to your excretion of the bilirubin through your bowel and through your urine and things. So basically it's infection, sepsis, and because of bilirubin is excreted through your urinary tract.
Thank you, Doctor.
Almost 5 PM already.
Okay. So if there's none, so Dahia nak proceed dengan Kahoot ke?
Boleh tak, Doktor?
Boleh.
So I will stop share now.
First of all, everyone please be ready. Get the best connection at your place. So everyone can see the screen now. So I hope everybody can participate. If there is any interruption, just you can just put it on chat or just turn on your mic. Okay. So everyone ready?
Yes.
Hello. So this comprise of three basically the three presentation. Okay. Let's see. Is the music is disturbing you all? Or should I turn it off?
Interesting music. Yeah.
If there's any problem, just let me know, okay? So I will just wait. The first part will be about the pale child, and the second part will be about the child with bruises, and the last part will be regarding the child with jaundice. Okay. So we are waiting for maybe 10 people maybe. Oh, presenter tak masuk eh? Presenter tak ya?
Yalah, nanti kah.
Dah tak jawab. So 27 lah kan? 7. Okay, another 7 people. Okay. Okay, go. 5 people more. Any more to come? Okay. Okay. Any more to come? Is there anybody have any problem? What is? There is check. Check apa tu? I think that's all. Okay. Can I start? Oh, okay. Okay, another 2.
Proceed. Lambat dah ni.
Okay, proceed Sorry siapa yang tak masuk lagi? Okay. So ready? There are 14 questions all together. Okay, the first question. Sam, 18-month-old boy come from Southeast Asia, reported by mom for being irritable, sluggish, and tired easily. Okay, time's almost up. Easy, right? Okay, so congratulations, all of you got the answer. So basically, it is a representation of anemic symptoms, which mostly in child they can appear in irritable, sluggish, and tired easily. Of course, the other answer is not so relevant, but if the patient have even mild anemic like pale, so we have to intervene and investigate further because it might be a serious condition. Okay, so congratulations. Next question. So it's complete. So here. All right, next. So this true or false? All right. So the most common cause less than 6 months old is IDA. So it is false because like I said earlier, because less than 6 months they usually breastfeeding, and breast milk is actually adequate to give the iron supply. So we should think of other diagnoses at this point of age, like hemoglobinopathies or blood loss or others. Okay, nice try. Okay, so he's still on the top, followed by the ends. Okay, next question. Following statements are true except. Okay, don't worry. Think of it. Have a plenty of time. Okay, some of you already got the answer. So you accept, yeah?
Mute Dahia.
Oh, tak dengar eh? Hello?
Lagu.
Lagu? Okay, okay. Tapi suara dengar kan?
Dengar dia.
Okay. Alright, so this is quite tricky because it asks about the false statement. So basically all are true except the iron study. So Let's go see one by one. So hemodialysis disorder is less likely. Yes, it's true. Because it said that it already ruled out the dark colored urine and so on, and Sam might having iron deficiency. I think maybe get a bit confused because the question asked for accept. So it show that the Sam is picky eater, less iron rich food. So we should think of he might having iron deficiency. Hemoglobinopathies could not be ruled out yet. Yes, because if you remember, Sam came from Southeast Asian, which is high prevalence of thalassemia, and which at this point of view, which have no history suggested to rule out the hemoglobinopathies yet. Okay, and why our study is wrong? Because if the patient's already history is suggestive of IDA. IDA studies is not really helpful to give a diagnosis, but we can start the treatment straight away. And also, the children also is less than 2 years, which is less likely to consider iron studies at this age. If you have any question, just interrupt me here, okay? Everyone clear?
Yes.
All right. Okay, so he is still on the list. Jap. Dah tak ada lagu. Okay, investigation revealed microcytic anemia. So what could be the cause of microcytic anemia? If you still remember the mnemonics. This is multi-select. Yeah, okay. So you got it right. So there are there are 5 causes. I see the little cells mnemonic. So IDA, thalassemia, and sideroblastic anemia can be one of the causes, and others like anemia in chronic diseases and lead toxicity. And in this child particularly, yes, Sam presented with microcytic anemia in his full blood count. We should think also the thalassemia, as I said previously, from Southeast Asian and so on. Sideroblastic anemia, usually because Sam is boy, so we should think of X-linked disorder also. But it's just a differential. Okay, next. Okay, so this one dah potong. Next question. So this is the last part. So Sam has been given oral iron therapy since the IDA is a final diagnosis. But however, HB level was not improved after 1 month. So what should we do next? Okay, so basically all are true. Okay, so when the patient after starting therapy, the HP is not improved, there are lists that we have to do, and it's stated in the pediatric protocol. First foremost, we have to ask for the non-compliance because the GI side effect and also the technique. The patient might be eating with drinking tea also on. So we have to assess the non-compliance, and maybe the iron dosage is not adequate. We have to increase until the maximum level until the HB also improve. And maybe the patient have some problem with iron absorption. We can consider parenteral iron. And at this point of view, we have to we can do iron studies because it may be helpful to confirm the diagnosis of IDA and also to rule out the IDA itself. So maybe it is an incorrect diagnosis. And the other list you can refer to pediatric protocol. So I pass next question to the next presenter. Okay, so still on the top. Okay, congratulations.
Okay, for the 6th question, choose one which describe the lesion. Okay, from this picture, which one is the answer? It is the easiest one. Where is the music? Tum.
Music dia ada je, tak dengar.
All right, congratulations for the 70 people. Ecchymosis is the right answer. So as I mentioned before, petechiae is less than 1 to 2 millimeter. Purpura is just a conjoint of the petechiae, and while hematoma is a palpable ecchymosis. So it is ecchymosis, most likely. All right. Next one. Okay, congrats Noor. Okay, next question. The possible cause for this kind of lesion, very obvious. Right. It is a sign of abuse since we can actually see the pattern of the bruises followed which whatever tools that the abuser has been used. Okay, so congrats. Next one. Okay, 10 years old boy, comfortable with swelling at the knee joint, multiple ecchymosis seen, no history of trauma. The possible diagnosis with the investigation result, platelet count is normal, PT is normal, but the APTT is prolonged. So what do you guys think? Plenty of time, think carefully. Okay, yes, that's right. It is a hemophilia. Okay, why it is not a why is not a chronic liver disease? Because the PT is normal in this case. If the only things that prolong is APTT. So which pinpoint towards hemophilia. Okay. Why not okay, tak apalah. It's
Sorry,
okay.
sorry.
It's okay, it's
Can I
okay.
proceed? Okay.
Yes. All right, 3 years old girl has high grade fever associated with cough for 1 week duration, no bleeding or rash noted. The possible diagnosis, the PT is prolonged, APTT is prolonged, platelet count also reduced. Lama juga. Alright, yes, the answer would be the IVC. Why it is not ITP? Because in ITP patient, usually the platelet is the one who affected. Coagulation factor doesn't play any roles in ITP. Okay. Eight-year-old had abdominal distension for 1 week duration. PE revealed ascites with jaundice. Mom is the known case of Hep D. The platelet count is reduced and APTT prolonged.
They got it so fast.
So fast. It's a simple one, I think, this one. Okay, chronic liver disease, 19%, 90 people is correct. Congrats. That's all, no need explanation.
Okay, so next will be the next Suzanne.
So the following is a false statement. So 10-year-old boy, persistent jaundice, intermittent itching, and the examinations reveals deep set of eye, hypertelorism, prominent nose, broad forehead. So which is a false statement?
This is distinction question.
Okay, so the answers would be features of unconjugated hyperbilirubinemia is the one that is false. So this actually is statements with regards to Alagille syndrome, broad forehead, long prominent nose, hypertelorism, and deep set of eye. So as I mentioned before, it is part of the conjugated hyperbilirubinemias. The problem is that there is a bile duct paucity. So conjugations occur, but it cannot be excreted out. So that's why we have it. The other one is true. Fish is used for diagnosis, microdeletion. Pulmonary stenosis, true. Butterfly shape is true. Next one. So Noor is leading the table. The following are factors affecting thresholds on nomogram, initiations of phototherapy and exchange transfusion, except. So if you look into previous protocols, there's a nomogram. So there are factors that affect the threshold to initiate phototherapy and also the exchange transfusion. So which are the following are not the factor that is included? Okay, so congratulations to one person. So actually, if we look into protocol, D6PD, isoimmune hemolytic disease, asphyxia and also sepsis are the factors that affect, and also gestational age affect the levels in when we want to start the phototherapy or exchange transfusion. And in addition to that, Nelson added acidosis and also temperature liabilities and also lethargy as part of the factors. So you can refer to your nomogram, the one that Prof. Ismail mentioned last week. Okay, ASTL does not affect our threshold to initiate when we want to start the phototherapy or exchange transfusion. Later on, the next question. Okay, so congratulations to Noor, still leading the table. Next. Okay, which of the following are the threshold for clinical jaundice in neonates? So neonates and children have different thresholds. So which are the following is for neonates? Okay, congratulations. So most of you answered it more than 85 micromoles per liter. So as doctor mentioned before, it is arbitrary. So it depends on multiple factors, but this is the values that is being quoted in the literature. Okay, the first one is actually with regards to the bilirubin encephalopathy. Those are the levels of unconjugated bilirubins that will precipitate the bilirubin encephalopathy. And then the 51 micromole is actually the levels of jaundice in adults and older children. And the last one is actually a random value, I just said. Okay, and next. Okay, so congratulations to Noor, still leading the table. Siapa Noor?
Best question.
Okay, following are features of chronic terrors except. Okay, so congratulations, most of you answered correctly. So the commonest sites would be in the basal ganglia and also the brainstem nuclei. The other are actually true with regards to bilirubin encephalopathy. Next.
Okay, so that's the last question.
Okay.
Okay, so we'll see the result. So the third place goes to Salhi. Congratulations. Second is A. Who is A? Please show yourself. And the first one go to Noor. Okay, congratulations to all. You can claim your gift from Nadira or Aklen.
No.
Okay, so thanks for participating, and hopefully you got some lessons from this our presentation, also this game. Okay, and then we would like to apologize for any shortcomings, and maybe Doctor want to add some points regarding today's presentation.
Okay, few more things. The first thing is you need to remember these are questions that that can come up in your exam, can come up in your theory exam. So few diseases that you need to know in great detail. As I mentioned before, asthma you need to know in great detail, dengue you need to know in great detail, and thalassemia as well you need to know in great detail. So thalassemia is a disease that you need to know in great detail. Thalassemia affects so many other systems as well. So you need to know about thalassemia. Especially I've told you before when we did the discussion with the whole year 5, isn't it? Before, I reminded you all that we have patients of thalassemia that they will come in your exam for professional exam, for block exam. So these are patients that we will call. Okay, one thing I need to remind you, this is COVID time. We're still in COVID time. So COVID time, we are still not entirely sure how your clinical exam is going to be. And definitely, as medical student, you cannot just pass based on just theory exam. You need clinical exam as well. Most likely, they're going to combine your clinical exam with the next group's clinical exam, most likely. But the thing is, whether can we do proper clinical exam in the hospital or not, we are not entirely sure yet. Probably there's a chance that among the things that we are thinking is actually we're going to call patient. We're going to call patient and probably one or two so it's like the man of ski style. So patient stay and then you go one round. So we need to call patient. And I need to remind you, if we call patient, we'll call from the stable patients who are already in our list. And as I've said before, we have so many thalassemia patients. So thalassemia is among the diseases that you need to know in great detail. Okay. Obviously, hemophilia, we don't actually have. I don't think we have any hemophilia here. But the thing is, these are things that you need to know lah. Okay. That's one.
Doctor, you are mute.
Okay, no, let me stop the recording because I want to say. Okay, fine. One last thing I just want to okay, basically macam ni. Account yang kita guna untuk Zoom ni is my personal account tau. Sebab URA kopi, URA kedekut, dia tak ada. dia tak bagi. URA ada satu account lah, which is difficult nak share apa semua, kita kena request semua. So what I did was because I use my account ni untuk banyak benda lain. There's so many. I use it for many things. Ada benda-benda yang lain, yang meeting lain lah. So it's also used untuk pediatric department punya meeting pun kita guna my account juga. So but I only record sebab kita punya plan your friends yang tak ada internet connection ni, so ideally dia boleh review balik bila kita share the video. Sebab tu kita record. The problem is I can only record in iCloud sebab yang boleh record only the host, and the host is only me lah. Maknanya kalau when I don't join, I tak tahu ada orang yang jadi host tak ada host kan, tak boleh record. So sebab tu only I can record. Sebab tu I record dekat cloud. So bila record dekat cloud ni, dia ada limited number of storage. So problem dia, contohnya macam tadi kan, Aklan masuk pukul 2, Aklan dah masuk dah. So recording start daripada pukul 2. Sedangkan tak ada apa-apa. Sebab kita start pukul 2.30. So sometimes bila you join too early, problem dia, lepas tu pula my laptop ni walaupun MacBook Air lama tau. MacBook Air lama ni dia tak boleh nak edit video tu, susah sikit. So maknanya kalau nak delete yang first half an hour tu, dia letih sikit. Sebab tu kalau you tengok yang our video yang ventilation strategy kan, part-part yang tak ada benda I tak edit sebabnya tak ada good punya laptop lah. So kalau you join too early, baguslah, I recommend. Bagus, semangat tu bagus, tapi maknanya you go join too early, recording tu start too early. Bila recording tu start too early, dia bazir space, bazir storage dengan bazir space. So okay lah, join mungkin 10 minutes earlier is okay. 10 minutes or 15 minutes earlier, I think it's okay lah. Tapi jangan lama sangat lah. Itu yang kedua, kalau boleh, mana kita kena kurangkan sembang ke apa dalam, sebabnya dia recorded ni, nak pause recording semua pun only me. Saya seorang dia boleh buat ni, pause recording, stop recording semua. Kalau tak, saya nak kena tengok video tu balik dan edit balik. So I don't have enough storage ni, dan URA tak nak bayar pula. This all comes from my own personal punya pocket lah. Tu nak kena remind lah. Okay, but it's okay, it's alright. Okay, I think that's all. Let's end our session with tasbih kafarah surah Al-Nas.
Thank you, Dr.